Our coordinator for today is also here.
Namaste,
Yeah.
madam.
So, good evening, everyone. I'm Dr. Achla Batra, co-convener for this certificate course on infections. Really honored by the task given to me. And before we start, I think if the uh, background team is ready, I would like to have a small prayer before we begin this second day proceedings. Can we have the prayer?
Sorry, madam. Actually, day one there was prayer. Day two and day three
Okay.
there is. Yeah, you can start. Yeah.
It's
We
okay.
can just
Okay.
start the program.
Yeah, okay. So yesterday we had a very good program with more than 1,600 registrations. The program started with basics, and then there was talk on UTIs, followed by tropical infections, which was really great by stalwarts Dr. J.V. Sharma, Josna. And then we had viral infections. Dr. Sadhna took hepatitis, HIV, and then it was also Dr. Girijawar took COVID and influenza. And to top it all, there was a panel on fever in pregnancy. So, for today's proceedings, before we start, I would like to call upon Dr. Sadhna Gupta to give her welcome address. Dr. Sadhna?
Thank you, Achla. First of all, a warm welcome to ICOG certification course on infection in pregnancy. That is second day. And we are grateful to have Dr. Sheila Mane, ICOG chairperson, who has given this opportunity for conducting this certification course, the topic which is very, very close to my heart, and almost I think the all of the great number you have joined, it shows that it is a concerning uh, a domain for every obstetrician and gynecologist, considering the great attendance from Pan India. Today we are going to have the focus on uh, the it is 25, the obstetrical sepsis. So this is yesterday we have the non-obstetrical infection, and today we are going to focus on obstetrical infection. And we have planned the program. It is not only the disease, but how we can prevent obstetrical sepsis, which is a big, big issue in our country, and I think globally, the way the antibiotic resistance is going on, and we are really struggling with the very resistant sepsis. So today we will have first the emerging concern and update how we can make our labor room and cesarean section protocol based aseptic precaution, right from the nurses and our mid-level staff to the senior person. And Dr. Smriti Agarwal, who has been the professor in Queen Mary, she will be covering that. Dr. Madhva Prasad will take a burning issue, that is multi-drug resistant organism in India, and how we can optimize the antibiotic stewardship. The second part is on the genital tract and the intrauterine infection and bacterial vaginosis, PROM and poliomyelitis. That will be taken by Dr. Sucheta Bachav and Dr. Rajeshri Kate. So the off and on, the people come with vaginal discharge, and every clinician must have that clinical acumenship, how to differentiate them from the normal thing and how to treat them well, so that we can prevent many, many obstetrical and the neonatal complications. Infection, puerperal sepsis and septic thrombophlebitis, that will be taken by Dr. Professor Saroj Singh. She has a great experience in the public health domain as a head of the department for the SN Medical College, Agra, and the great teaching experience. And Dr. Veenu Kushwa, who is again professor in Madhya Pradesh, she will be taking the septic thrombophlebitis. So we have taken a little bit because septic thrombophlebitis need a different approach. For the sepsis, the new marker and the sepsis care bundle, that will be taken by Dr. Shikha Seth and Dr. Sarita Agrawal. And this is the surviving sepsis campaign, which the FOGSI, ICOG, and we are really looking that the surviving sepsis campaign, the updated guidelines are followed all over the country. And that will be followed by the panel discussion, the clinical case-based discussion on severe maternal sepsis and septic shock by today's the co-convener Dr. Achla Batra and Dr. Vidushi Kulshesh, and we have the learned panelists from all over the country. So today we are going to gear up for a very, very focused program, right from prevention to the ICU care in the sepsis. And sepsis is considered silent killer. It kills like a thief, and we are suddenly lost at what is happening. So we wish very, very happy learning. And before this, I invite first of all Dr. Sheila Mane for her blessing, and then I will invite Dr. Ashok Kumar, who is the chairperson elect of the ICOG, to all the participants for their blessings and for their welcome address.
Thank you. Thank you, Dr. Satna. I think we already know the importance of this, and I had it in my mind since I had taken over. I was just thinking we must have a certificate course on this, and I must tell you the feedback everybody is really appreciating, because these are all the practical tips, for your day-to-day practice. It is very important. And yesterday we covered all the non-obstetrical infections, and I must tell you that maternal death review, when we do, we find that sepsis has been neglected. So the aseptic precautions, whatever precautions to be taken in labor room, in cesarean, plays a very, very important role when to give a prophylactic antibiotic. Because when it is neglected, what happens, most of the time we see the patient where she is already in a severe morbid condition. So it is very important, today's session particularly, as it deals with obstetric sepsis, which I feel, is the whatever guidelines are there are not being followed there. We always look at PPH, hypertension and all these things, but sepsis also is responsible for severe morbidity and mortality. So I think today's session will focus on that, and which is very important for our day-to-day practical mind. So thank you, Dr. Sadhna and Dr. Achla Batra, today's conveners, for starting this program with such a good messages. And I welcome everybody on behalf of ICOG once again. And I think we should proceed. I think if Dr. Ashok Kumar has joined.
Yes, ma'am. Sir is joined. Sir is there. Yeah.
Welcome, Dr. Ashok Kumar, who is ICOG chair-elect, and a great conference organized. We have just witnessed and enjoyed the ICOG 2026, and Dr. Ashok Kumar is a great academician. It's ICOG really like a lucky fortunate to have the person like Dr. Ashok Kumar of that caliber. We invite Dr. Ashok Kumar for his welcome address and his pulse of wisdom. Dr. Ashok.
Thank you, madam. Good evening to all. First of all, thank you, Dr. Sheila Mane, Dr. Sadhna Gupta, Dr. Pratik Tank, for organizing this certificate course on infections. ICOG is an academic wing of FOGSI, and it is an endeavor to spread the knowledge and to update its fellows and members about what is happening around the world in the scientific knowledge, and to improve the patient care. So these type of activities are really important. I will not go into the program. Dr. Sadhna madam has already given you insight about the program, what all is going to happen. And yesterday also it was a very good deliberations, and everyone enjoyed. So I just would like to thanks and welcome the faculty members who are delivering their talks and who have taken their valuable time, and they are participating in this, and all the chairpersons and delegates and the participants. So thank you very much. I hope that you will continue to be associated with ICOG and continue to enjoy the academic feast which ICOG gives you on a regular basis. So thank you very much.
Thank you. Dr. Pratik is always there, and his background, he is all alert and observing everything. Dr. Pratik, we invite you to say a few words, and before our co-convener, Dr. Shlabatra, and our convener of the day, Dr. Kanchan Prasad, who has done a very hard work for this coordination, they start the program. So Dr. Pratik, few words from your side.
Thank you very much, Dr. Sadhna Gupta, and the conveners and coordinators for all 3 days. Mammoth task organizing a certificate course, and you have put in a lot of efforts to bring in faculty from all over the country, different parts at various levels of expertise. We are very happy to see a record number of attendees, and I urge all of you to stay right till the end, attempt the post test on all 3 days, and then receive the certificate for this particular course. Thank you very much. Let us proceed.
So, I think Dr. Kanchan Prasad, who is the coordinator of the today's program, and she is professor of at Moradabad Medical College. So, Kanchan, you can start the scientific session.
Thank you so much, ma'am. And first of all, I would like to express my gratitude to Sadhana Gupta ma'am, Sheila Mane ma'am, and Pratik Tambe sir for giving me opportunity to coordinate today's program. And let us start the first session of the program, which is on emerging concerns and updates. And to chair the session, we have two very eminent chairpersons, Dr. Revati Janki Ram madam and Himali H. Sinha ma'am. And Revati Ram ma'am is a very known person. We all know her. She is Vice President FOGSI from South Zone during 2016. And she is recipient of many awards, including very distinguished award, that is Durusa Community Services Award and Lifetime Achievement Award from IMA Madurai. I welcome you, ma'am. And our second chairperson is Himali Sinha madam, a very academician at PAR, and she is retired professor and head of from OBGNY AIMS Patna, and she is vice president ISOPAR during the year 2025 and 26. Welcome, ma'am. And now I hand over the session to two chairpersons to proceed and introduce our speakers.
Yeah. Good evening, dear friends. Thank you, Kanchan, for a nice introduction. As we all know, maternal infection, especially contracted in labor ward, forms a major chunk of a preventable cause of maternal mortality. So, following good clinical practice and especially following specific protocols for infection prevention is very, very critical. And here we have got Dr. Smriti Agarwal to talk about the protocols on prevention of sepsis in labor ward. She is a professor and Vice Dean of College of Nursing, ex-HOD of Department of OG in Lucknow. And she has a lot of awards and honors to her credit. And her interest is in fetal medicine as well as reproductive medicine. And also she has got a lot of publications, more than 77 publications in reputed international and national journals. And I request Dr. Smriti to talk upon the prevention protocol of labor ward sepsis. Over to you, Dr. Smriti.
Yeah.
A very good evening. I hope I'm visible and I hope I'm audible too.
All good, ma'am. Please go ahead.
Yeah, okay. A very good evening, respected the entire ICOG team, the chairpersons, and the chairperson of this session. And Dr. Revati ma'am, I only want to say I am a proud alumni of Madras Medical College. And I also received my OBGYN training from IOG Chennai. So it's an honor for me to be part of the stalwarts here. I'm going to be talking about a very, very important topic today, which is what can we do as obstetricians for prevention of sepsis, both in the labor room as well as during cesarean sections. So before I begin, we are all committed that no women should die of infection of childbirth. We know MMR is definitely coming down in India, and it is 97, and we are slowly inching towards SDG of 70 by 2030. But in 2021 also, we know that around 12% of maternal deaths happen because of infection. So this is a very serious matter. The WHO has defined that life-threatening condition which leads to period. And it is a emergency, just now Dr. Sheila Mane ma'am was also saying that we talk about PPH, we talk about a lot of things, but sepsis is an equivalent obstetric emergency which we need to look at. Now, when we speak of what can we do in the labor room, there are standard precautions which starting from the residents to the entire team of doctors, the faculty, the nursing, everybody knows that there are certain things which are definitely followed. One is hand washing, use of protective attire, decontamination, sterilization of equipments, hand handling and disposal of biological waste disposal, and companion of a choice to make her labor a pleasurable experience. We know that washing hands, we cannot overemphasize in what we already do, that washing hands is an extremely important step in order to prevent the sepsis, and also wearing the protective attire. Of course, the instruments, we know that the instruments need to be, the reusable instruments need to be decontaminated in bleach. Then they need to be cleaned with the soap water. And after that, they have sterilized and they can be used. Also, very important aspect in labor room is that the entry to the labor room, there should be a buffer zone, so that there is a place where the shoes can be changed and the people who are entering the labor room can wear cap and mask in order to reduce the incidence of sepsis. Now, in labor room practices, there are certain things for hexadine or povidone iodine. When we are rupturing the membrane, it should be done as aseptically as possible in order to reduce the postpartum endometritis. At the same time, perform PV examination only when required. In medical colleges, we often see that the residents they do sometimes PV examinations when they're not monitored very frequently, especially when everybody when their duty begins, and this is a practice which needs to be strongly condemned and it should be avoided. Similarly, we should not encourage shaving of the pubic area, avoid enema as much as possible, avoid episiotomy and give selective episiotomy only in certain cases, and do not do routine suctioning of baby. Now, it is very important that these labor room practices are followed in order to reduce the sepsis. Now, in labor room protocols, there are certain things which are extremely important, which is how the labor table and the labor room should be cleaned after each shift and after each delivery. Well, it should be cleaned by clothes soaked in clean water, as well as in the 0.5% chlorine solution. We must remember that the genital forceps, which are used in order to pick up the pads, sterile pads, to pick up the sterile instruments, it should never be kept in antiseptic, as we very often see in some of our district hospitals or in the periphery, that they're kept in a jar which is filled with Savlon and cotton. However, the genital forceps should be kept in an autoclaved jar, and that jar should be autoclaved daily, and there should be a date and time labeled so that we know that we are dealing with a sterile genital forceps. Toilets, along with the labor room, should also be cleaned with the phenyl or Lysol at the start of each shift and after each delivery. A lot of times it happens that we always forget about the overhead tank. And in KGMU itself, we recently had, when we were doing an audit of the hospital acquired infections, we realized that there was a species of Acinetobacter baumannii, where it was active, and then the overhead tank supplying water to the labor room was also cleaned. And as a protocol, we should try cleaning it at least once in a week, or if it is not possible, then at least fortnightly or monthly, the overhead tank also should be cleaned. In the morning, when you begin the shift, the floors and sinks should be cleaned with a detergent or chlorine solution, and thereafter every 3 hours. All the tabletops and the surfaces like almirahs, lockers, etc., should also be cleaned with low-level disinfectant like machines or our workstations. They should be cleaned with 70% alcohol. Now, what happens is we know that obstetrics is sometimes a messy affair, and it leads to spillage of blood on the floors. It is important that whenever there is a spillage of blood, it should be first soaked with chlorine solution for 10 minutes, and then we should either put some kind of an absorbent paper on it so that it is able to absorb most of the liquid, and that absorbent sheet should be then discarded in the appropriate plastic bin. Similarly, every labor room table should have a disposable absorbent sheet placed on it so that there is no spillage of the blood on the either side of the table. The tabletops, however busy the labor room is, one patient goes and before the other patient comes, should be thoroughly cleaned with chlorine solution or disinfectant. It's very important that mopping also should follow a particular protocol, which we call as bucket protocol, where we can use phenyl or Lysol or bleaching solution in one of the buckets. And it should be done thrice in a day, and whenever we realize that the floor is looking dirty and it is contaminated. Now, we know that most of the hospitals, we of course follow the biomedical waste disposal. I'm not going to highlight that because we have all been following this rigorously. Now, this was about the labor room protocol. Now, let's come to what are the things we can do when we are doing cesarean sections in order to reduce the incidence of sepsis. Well, what are the two important things is management of comorbidities and identification of risk factors. Now, we are all very, obviously, when we are doing a surgical procedure, antibiotics obviously have their own role, but it is important that prophylactic antibiotics, they should be given before the skin incision, and this is endorsed by NICE guideline as well as the WHO guideline. So there was a time when we were residents, when antibiotics were being given after the cord clamping in order to, reduce the neonatal bacterial resistance. But this is not the case now. Whenever we do a cesarean section, we should give it 30 to 60 minutes before the skin incision. Now, what antibiotic? We will come to that in the next slide. A higher dose of prophylactic antibiotics should be considered when a woman is obese, because we know that these drugs get distributed in the fat, and thus their efficacy may come down. Now, most of the guidelines recommend that we must give single dose of first generation cephalosporins, cefazolin or penicillin for prophylactic antibiotics. Maximum antimicrobial prophylaxis should be a maximum of 3 doses within 24 hours, since it's a BD dosing. So 1 before the surgery, 1 in the evening, and 1 the day after, and that is all. Now, multiple doses of prophylactic antibiotics by the evidence has shown that it definitely reduces the risk of endometritis. 68% was when multiple doses were not given, and it reduced to 57% when multiple doses of prophylactic antibiotics were given as compared to a single dose. But the idea is that these multiple doses, they should not be given routinely. Only if we think that the surgery is prolonged more than 2 hours, or if a woman is experiencing heavy blood loss, then we must consider giving multiple doses. Otherwise, just a single dose should be more than enough. Now, if a woman has got penicillin allergy, then those women, we must, ACOG recommends that we use clindamycin and an aminoglycoside followed in a lot of labor rooms. Now, it is important that routine perineal and pubic hair shave, it should not be done, because it is not found to have any kind of a clear beneficial effect in site infection. So only the long hair should be clipped and shaving should be avoided.
Your voice is breaking, Smriti.
Your voice is not very clear. Can you just see if the network is okay?
Just give me a minute.
Many chat box, I think there are many messages. Just see, your voice is breaking. Just check.
Okay, ma'am. Is it better now?
Okay, fine.
So, ma'am, should I redo some of my slides or should I continue?
No, please proceed from this point on.
All right. So now one very, very important method which has been used and tried and tested, and there is an evidence now to suggest how to reduce postpartum sepsis is routine preoperative cleansing of vagina. There is an article which is systematic review and meta-analysis which is published in American Journal 2026 recently, and that systematic review said that in the women who have a pre-labor cesarean delivery, which is electrocesarean sections, the patients who did not receive vaginal antiseptic had a 3.53 higher fold of having endometritis compared to the women who had chlorhexidine vaginal wash. Even the intrapartum cesareans, where the women were in labor, if the chlorhexidine vaginal cleansing was done, the chances of endometritis were much lesser. And if it was not done, the odds were 2.7 times higher. So this has come out to be an extremely important evidence-based practice where vaginal antiseptic preparation significantly reduces the odds of endometritis, wound infection, wound complications, and postoperative fever. And usually the recommended concentration is 0.1 to 0.5%, but we must try and use whatever is available to us in order to reduce the maternal sepsis. Now, preparing the site, surgical site before the cesarean is extremely important. We can either do it with chlorhexidine with an alcohol preparation or povidone iodine, and both of them have an equal efficacy. For choice of skin incision, NICE guideline recommends that if we use a phalansteal incision, which is 3 centimeter above the pubic symphysis, then it definitely has a very good advantage and better chances of healing, less chances of surgical site infection. The Joel Cohen incision has no advantage because initially it was thought that because it was a blunt dissection, it was associated with good outcome. But however, now the evidence says that phalansteal incision is definitely better and is highly recommended. Now, another one very important OT practice is glove change. Now, when I was preparing, I realized that there are systematic reviews and meta-analysis to suggest that if we are changing the gloves after the placental delivery, it reduces the rates of endometrial sepsis to a large extent. This meta-analysis was published in 2021, and it said that glove change reduces the risk of surgical site infection by half. The pooled relative risk was 0.49. Compared to no glove change, however, this did not reduce the risk of endometritis or febrile morbidity, but definitely reduced the risk of surgical site infections. Another systematic review published in 2021 only said that if you are changing the gloves after the delivery of the placenta, then you can reduce the incidence of surgical site infection by 0.37. So there are 2 systematic reviews to suggest that, and I think it is a very easy method and a very effortless practice which we can adopt in order to reduce surgical site infections. Now, what about perioperative oxygen supplementation? Well, there is no role. There is no role of intra-abdominal saline irrigation after cesarean section. Whether you are doing the suturing or you are doing stapling, again, there is not much difference. But we must remember that in obese women where we are doing a cesarean section, the Cochrane database suggests that if we are using a negative pressure wound therapy, it reduces the incidence of surgical site infections, and this is published in 2022. So that was about what are the things we can do during the cesarean section. Of course, postpartum sepsis can still happen despite our best labor room practices, despite our best cesarean OT protocols. Now, it is important that postpartum sepsis is recognized and managed. I'm sure we have lectures subsequently where we will be talking about how this sepsis is recognized, and we will also be talking about the sepsis 6 part of the management which is to be followed. FIGO has released this chart where it highlights what are the important things which we can do both antenatally, intraoperative, and postnatally in order to reduce the postpartum sepsis. And in the intraoperative, it highlights that definitely role of prophylactic antibiotics 30 to 60 minutes before the cesarean section. If a patient has PRON, then we can also add azithromycin. Do proper cleaning of the skin with chlorhexidine alcohol, and also do vaginal cleansing with chlorhexidine alcohol, without alcohol, chlorhexidine preparation, and also change the gloves after you have delivered the placenta and before the closure of abdominal wall. So these are extremely important practices which can help in reducing the postpartum sepsis.
Sorry to interrupt you, ma'am. Your time is up.
Yeah, this is my last slide. So we must remember that no women should die from giving childbirth, and we must do our best. These are my references. This is from FIGO 2025, and of course, the National Health Mission guidelines and the WHO delivery protocols. Thank you so much.
Thank you, Smriti, for a nice talk. I really congratulate ICOG for planning such a wonderful topic, because the participants, especially those who are having smaller hospitals, they will learn the practical points which they have to follow regarding the protocols in preventing infection in the labor room as well as OT. It's very, very important. And the active participation of the members in the chat box, putting a lot of questions there. I think she can answer later in that because we are running short of time. Then can we move on to the next session or any interaction?
Now let's go on to the next
Yeah,
speaker.
that's better. Sorry,
The
want of time
speaker
we have to proceed.
can
We
take the
proceed.
questions in the chat box itself.
Okay, yeah,
Save
yeah.
on time.
That is it. Then the next CV of the next speaker, and I think Hamli she can introduce the speaker.
Good evening. Thank you, ICOG, for inviting me. I'd like to invite the next speaker, Dr. Madhav Prasad, who's Associate Professor Obstetrics and Gynecology and Associate MS Pharmacy at St. John's Medical College, Bangalore. And he's the National Corresponding Editor, Jogi 2123. He's also faculty Department of Medical Education at St. John's and a review of maternal research studies. He'll be talking about a very vexing problem which we are facing these days. That's multi-drug resistance organisms and antibiotic stewardship. Over to you, Dr. Madhav.
I think you're muted, sir. We can't hear you. We can see your slides, but we can't hear you.
Sir, we can't hear you. Kindly unmute yourself.
Nope, we still can't hear you.
Pratik, can you tell the backend team to do something?
Maybe just unplug the headset and just shout very loudly at the screen.
Okay.
That might work. Yeah, now we can hear you.
Yes, sir.
Sir, you are not audible, sir. No, sir.
You can hear us, but we can't hear you.
All is well here.
You can disconnect the Bluetooth.
Correction. Okay, can you hear me now?
Yeah, we
Yes,
can
sir.
hear you now. Like I said, just shout very loudly at the screen.
Okay. Shall I start?
Please go ahead.
Okay. So I'm bringing greetings from Bangalore, and a note on why I was quite lucky to get this topic, because I was I'm a associate medical superintendent in charge of pharmacy services, and one of the responsibilities that I have is to audit high impact medications, and these high impact medications include antibiotics. So I've been seeing that there's quite a bit of irrational usage, and people need to be reminded that, these things are quite important. Just because something is available doesn't mean we use it, right? So every institution needs to have an antibiotic protocol, and this is something which has been available in this institution for quite some time. Now, there are forms which have to be audited regularly, and this is part of the ecosystem where the administration also comes in. So coming to the main topic, so what is the problem? The problem is antimicrobial resistance. It's a major global health problem. Now, why is it relevant to us? It's because we spoke about surgical prophylaxis, urinary tract infections, sepsis, premature rupture of membranes, chorioamnionitis. All these things are very much associated with the antimicrobial resistance, right? So if you look at a quick review of literature, we are seeing that quite a few pregnant women have subclinical bacteriuria, but it can progress to pyelonephritis. Has it increased? Yes, over time it seems to have increased. So if you review the literature in the recent past, there is multiple local studies and multiple cohort studies which have been telling about the increasing bacteremia, which includes Enterobacteriaceae, the gram-negative organisms which are most commonly implicated. Now, something which we need to draw attention is something called an escape. Is a usual spectrum of organisms which include Pseudomonas, Klebsiella, aureus, and Enterococcus faecium. All these things are beta-lactamase resistant, and their incidence has increased majorly in the recent past. You can see it very clearly. Dramatic increase in escape organisms, and these are going to affect our branch, which is obstetrics and gynecology. So, there is extensive literature to tell that there is a multitude of entities which are causing problems. That includes poor prescription, poor monitoring, and problems which are in the nearby countries. There is so much of travel. All these things are impacting antimicrobial resistance. So, which are the main drivers of antimicrobial resistance? These are poor prescription policies, poor rationality, poor administrative surveillance, and there is a financial component. Antibiotics are costlier. Pharma companies are trying to push it more forward, and things like that. So there are multiple drivers of antimicrobial resistance. So the Indian document, the standard document released by ICMR, says there are some 30% facts. 30% of all hospitalized inpatients at any time receive antibiotics. Over 30% which are prescribed are inappropriate. 30% of surgical prophylaxis is inappropriate. 30% of hospital pharmacy costs are due to antimicrobial usage, and 30% antibiotic cost can be saved by stewardship program. So look at this. There is a large number. 30 is 1 in 3. It is affecting you and me and all our patients day in and day out. So just to summarize, it's a real relevant, and it has an increasing prevalence, and it has medical, behavioral, administrative components, and financial components also. If you don't correct it today, there is going to be untreatable infections tomorrow. So coming to a specific definition, what do you mean by multi-drug resistant organisms? Are defined as those microorganisms, predominantly bacteria, which are resistant to one or more class of antimicrobial agents. So usually what happens is, once an organism develops a resistance, if it is resistant to one, there is a high possibility of resistance to the other, right? So what are the reasons? One, cellular that keeps evolving, but more importantly, wrong diagnosis, lack of prompt initiation, inappropriate usage, too much, too long, and lack of surveillance mechanisms. So all these things are the broad reasons for emergence of MDR organisms. So if you look at it, sometimes wrong diagnosis can also be a problem, where initially the patient was being treated for a wrong illness. That will lead to continued transmission, and then at that point in time, there can be a waste of antibiotic resources and increasing the burden. So this is one mechanism. So it is very important to diagnose an infection promptly and correctly. Now, there is this concept of antibiotic pressure. There is genetic selection. The organism is going to keep mutating, but that mutation is actually enhanced by the wrong antibiotic. So that is something that we need to recognize. So there are multiple, we have read this in pharmacology, we need to recollect this. There are efflux forms, there are decreased uptake, there are mRNA alternation, there is inactivating enzymes, so many things which are taking place. Maybe as a practicing clinician, it is not very important, but just suffice to know that the mechanisms are aplenty, right? This is a very, very important slide. You can look at that picture there, right? There is a flower and you have to remove it. Do you really need an instrument to remove a flower? In Tamil, there is a song which says "Pupparika kodali edarku," which means, do you really need a large sword to take out a flower? That is exactly what is being happening, and that is exactly the concept which has to be applied in antibiotic de-escalation. A higher antibiotic is not needed for a lower organism. So it's not just about how fast you accelerate, you should be able to slow down also. If this concept, if we are able to get in, it is worth it. So what is the importance to OBGYNs? There is a high burden of resistant gram-negative organisms, and E. coli is more than 50% ESBL, that is extended beta lactamase producing organisms. They are resistant, right? So now you may ask, oh, I do everything correctly, but just think about it. Just think about it. How many times do we actually start an antibiotic without a culture? How many times do we actually look into a prolonged surgical prophylaxis even without any particular reason? Do we treat UTIs without cultures? Do we give more than one antibiotic, when a single antibiotic will suffer? If there is a patient, high profile, whatever, whatever the reason is, one post-operative spike, do we investigate or do we change antibiotics? I'm sure you would have listened to the last 1 minute very carefully. Think about it. These are practical scenarios that we look into every day. And if you are jumping to change the antibiotic or add an antibiotic or not do a culture and start the antibiotic, then somewhere there is a problem, right? So problem is defined. Now, what is the solution? That is where we come into the National Action Plan for Combating Antimicrobial Resistance. So these are the broad points. Curb antibiotic resistance, strengthen an antibiotic resistance surveillance, advanced development of rapid diagnostics so that diagnosis is not missed, accelerated research targeting, and collaborate for prevention, development, and surveillance efforts. So these are the broad points. Now, this is a national action program. Now, you think globally, but you act locally. So that comes to the core elements of antibiotic stewardship, which is, see, you can see there are multiple elements, support the surveillance, reassessing treatment when culture results are available, use the shortest duration of antibiotics based on evidence, prescribe appropriate antibiotics only, prescribe only when they are needed, enhance, the education of the staff. So you can see that antibiotic stewardship is not just one activity, but there are multiple activities of the same, right? So at every level, in the hospital level, the primary goal will be to optimize safe and appropriate usage of antibiotics. And the secondary goal would be to reduce healthcare costs and reduced incidence of antibiotic-induced problems, right? So what are the various problems? So somebody already spoke about optimizing antimicrobial prophylaxis for operative procedures. Now, development of guideline, whatever the type of patient is, development of a guideline is very, very important. And prospective auditing, somebody neutral should be looking at whether the antibiotic that is prescribed is appropriate or not appropriate. Formulary, half of you may not know what a formulary is. In large institution, there is a formulary. A formulary means there is a set, limited amount of antibiotics or limited amount of drugs that are available. Only those are available and the others are not available. If you are going to go for out of formulary, then you need to have administrative clearance. That is where the restriction comes in. That's what is meant by formulary restriction. And improving antimicrobial prescribing by educational and administrative means. These are some of the strategic approaches. We look into a few of them in a little more detail. So you can see here, the core principles are the right antibiotic given for the right dose at the right interval and for the right duration, right? So it's very, very important to ensure that these protocols are followed. Now, if an IV was going on, can it be switched to oral? Can it be de-escalated? De-escalation of the antibiotic is a very, very important. So again, just to summarize, audit, pre-authorization, conversion to a lower antibiotic or an oral therapy, and use of microbiology in conversation at all points in time. So to improve all these things, education is definitely needed. People need to. So here, what we are doing right now, we are getting ourselves educated. Like this, it should happen in every institution also. And guidelines and clinical pathways should be clear and should be established. So what are these? They will be local antibiogram based. Your institution will have a local antibiogram and they should be syndrome based. That should be very clear. The outpatient treatment is different, inpatient treatment is different, ICU setting is different. Why that particular guideline is utilized, what is the evidence base, and the physicians should know what is there, and they should own the guideline and follow the guideline, right? Just an example which is provided. This is not hard and fast. An uncomplicated UTI should not be treated for more than 7 days. So like this, there are so many of these guidelines which are there not only for OBGYN infections, but for others also. We have to tailor make our own clinical standard guideline and ensure that they are followed, right? So this is a kind of pathway where you are going to de-escalate the antibiotic. So you started a higher antibiotic, example, meropenem, for some a higher growth. Now, if the patient is clinically stable, no fever, WBC is going down, and vitals are stable, able to tolerate intake, then what? You have to convert to oral. If any of these things, these red flags still remain, then continue IV. So we have to keep questioning ourselves, what is the trend? How is the patient improving? And is it possible for us to remove the higher antibiotic and move to a lower antibiotic? That is the crux of antimicrobial stewardship. Now, this whole thing you are describing, and how are you going to monitor the process? I already explained my, experience. I am the AMS pharmacy of my institution, and every month we meet to look at higher antibiotic usage. We see how many times, say for example, meropenem has been requested. Say for example, recently there was a sulbactam, durlobactam request. Now, is it really necessary? Where is it necessary? Antifungals, are they really necessary? So we are going to audit all these things, right? So antimicrobial stewardship also includes hand hygiene, surgical asepsis, proper catheter care, rational CS indications, early removal of catheter. All these things are going to be covered in different parts during this 3-day session. However, these are also components. So the takeaway message is that MDR organisms are increasing in India. Obstetric practice frequently involves antibiotic usage. Misuse accelerates resistance. Antibiotic stewardship is a clinical responsibility. It's a multidisciplinary approach. Small changes can help and preserve antibiotics for the future. I hardly covered anything in 15 minutes. We have not looked into exact antibiotics usage. We have not more time to go into specifics. What is XDR? How to treat? We have not gone into any of those things. And don't wait for your antimicrobial steward to come and teach you how to reduce infections. You can be the antimicrobial steward yourself. You don't need a title to be a leader, right? So those who have your screen on can just take a screenshot of this or a photograph of this. This QR code will lead you to the existing ICMR document on antimicrobial stewardship. Happy reading, and thank you.
Thank you, Dr. Madhav. That was quite elaborate in 15 minutes. You covered a lot of things, especially I like the way
Madhav, keep that scanner for that one for some time. Madam can talk in the background.
Yes, ma'am.
Yeah.
Because everybody must have not taken the picture.
Right. So you talked about each institution having its own antibiotic policy and the antibiogram that needs to be looked into. And you're right that appropriate antibiotic selection is important. The optimal dose, route, duration, de-escalation, of course, is very important. And culture-guided therapy instead of using arbitrary, use of antibiotics, as well as the restrictive policy. Again, we require regulation of antibiotic sales. I don't know how far we can manage with this. Improving diagnosis, public awareness is again important. So thank you very much for your talk. Thank you, ICOG, for inviting me.
Any questions you can answer in the chat box, Madam.
Thank you. Thank you so much, both the chairpersons and speaker, for excellent talk and excellent discussion. Now we can move to the next session. And next session is on genital tract and intrauterine infection. And to chair the session, we have three learned chairperson, Dr. Anuradha Khanna Madam, Dr. Devang Patel Sir, and Dr. Kasturi Rominath Madam. Can we have the CV of Anuradha ma'am? Anuradha Khanna ma'am is a very renowned figure, and she has been on very prestigious post, including President UPCOG and current. She is ex-HOD of the Obstetrics and Gynecology Department, BHU. I welcome you, ma'am. Can we have the CV of Devang Patel, sir? Sir is consultant obstetrician and gynecologist at CIMS Hospital, Ahmedabad, and director, Gujarat Fetal Medicine Center and Divine Women's Hospital. I think sir has sent an apology that he is stuck in an emergency or he may not be able to join. Can we have the CV of Kasturi Dominath, madam? Madam is director at Tatwardha Hospital, Hubli, past president Kasoga, ex-secretary Department of Obstetrics, KIMS Hubli, and ex-president of HDOGS, ex-secretary general HDOGS. I welcome you, ma'am, and now I hand over the session to both the chairpersons. Kasturi, ma'am? Yeah.
In place of Dr.
Welcome, ma'am.
Devati Patel, we can request Dr. Harish Doshi sir to chair. Sir is well known to all of us, legendary OBGYN. Thank you very much, Dr. Harish Doshi sir, for joining us.
Yeah. First of all, good afternoon, everyone. First of all, thanks to ICOG team, Sheila Madam and Pratik Tabe sir for inviting us to chair this. Today's session is very important, excellent, very important topics to prevent the infections. So now we have a next this thing by Sucheta, Dr. Sucheta. She is a course consultant and director of Tulsi Hospital, Nasik, past president of Nasik OBGYN Society, director of Save Girl Child Empowerment Committee of Government Hospital, Nasik. She is co-founder and in-house obstetrician for Tulsi Maternity and Surgical Hospital. She has received many awards. She has many awards to her credit, like Dr. Anandibai Joshi Award by Government Hospital, Nasik. It's such a proud moment to have Dr. Anandibai Joshi Award and Dr. B.C. Roy Award and first female chairman of Nasik District Hospital Cooperative Bank. Welcome to you, madam. And very important topic on bacterial vaginosis. We are very eager to hear from you, madam.
Thank you, madam, for lucid introduction by Dr. Kasturi. I'm privileged to be here at the ICOG webinar, and I'd like to speak on bacterial vaginosis, which is the commonest thing which we come across. Can I share my presentation here?
Yes, please, ma'am. Please go ahead.
Oh, I have already sent it to you. Kanchan, can I share it?
Nilima?
Yes, just a minute. Just now we are received. Just Shreya will share you. Just give 1 minute.
Yeah, sure,
If
sure.
there's going to be a delay, then we can take the next speaker. I see Dr. Rajeshri Katke is already here with us.
I have already shared it. Just take a minute. Just not less than a minute. Thank you, Pratik.
So there is a question in the chat box. I will not be able to attend between XYZ to ABC time. Please suggest how to take the post test. You can carry your phone with you and you can attempt the post test on the phone. Thank you very much.
That can be done. Yeah, it has been done, Ankit.
Not yet seen, madam.
I have already said.
Just 1 minute, ma'am.
Tambe sir, it was very excellent topics chosen, very nice. Even the previous
Credit goes
topics.
entirely to the organizers led by Dr. Sadhana Gupta, the conveners of the 3 days and the very hardworking coordinators of the 3 days. I cannot claim any credit.
I'd like to thank Dr. Sadhana Gupta, Dr. Sheila Mane, Dr. Kanchan, and Pratik, my best friend.
Ma'am, now you can start, ma'am.
Yeah, sure. But how to scroll?
You'll have to say next slide, next slide.
Okay, I'll have to say. Okay. As a bacterial vaginosis is very common and commonly seen in day-to-day practice of ours. So we are dealing with the commonest thing which is seen, which has to be treated at the general practitioner levels. But we have to percolate this to them so that they get accustomed to treat this bacterial vaginosis, so that we'll find less and less patients of infertility having PIDs. At the outset, next. Bacterial vaginosis is a clinical condition characterized by a shift in vaginal flora away from lactobacillus species towards more diverse bacterial species, including facultative anaerobes. Bacterial vaginosis is not a sexually transmitted infection. Other names to bacterial vaginosis are anaerobic vaginositis, non-specific vaginositis, vaginal bacteriosis, and Gardnerella vaginitis. This condition is called bacterial vaginosis, not a bacterial vaginitis, because it is caused by bacteria and inflammatory response is lacking there. So, however, bacterial vaginosis is the most common cause of vaginal infection in reproductive age group. Next. Bacterial vaginosis is the most common infection encountered in outpatient or OPDs and gynecological and non-gynec settings too. So it is typical having a symptoms of thin gray homogeneous vaginal discharge. At times may be associated with fishy vaginal odor. There may be associated vaginal irritation, dysuria, and dyspareunia. On wet mount microscopy, if done with saline preparation, we can always see the bacterial vaginosis and diagnosis will be confirmed with that. The asymptomatic bacterial vaginosis will resolve with the treatment, without treatment at times. But symptomatic bacterial vaginosis usually needs a treatment with antibiotic therapy. The antibiotics which are mainly used are metronidazole or clindamycin. Next. So general population which are having prevalent bacterial vaginosis is globally seen in nearly 23 to 29% across India. Usually it is more common in Black and Hispanic women, but it is estimated that global economic burden treating bacterial vaginosis in US FDA is nearly 4.8 billion. So see how much of a expenditure is going on for bacterial vaginosis. If it is treated early, so we'll get the early results and we'll get a better patients for the next generations. Economic burden of bacterial vaginosis is increasing when including cost of bacterial vaginosis associated with preterm birth and also in HIV cases. Next. So risk factors of bacterial vaginosis are listed below, which are recent antibiotic use, decreased estrogen production of the women who are in perimenopausal and menopausal age group, having IUCD inserted, then in reproductive age group, then douching and tub baths and bubble baths, and also frequently going to the swimming are also included in this group. Intravaginal hygienic products, if commonly used, they are also prone to this type of infections. Liquid soaps and body washes. Liquid soap and body washes, if they're put in vagina, the people are more prone to it. The sexual activity, which also gives rise to bacterial vaginosis, is multiple sexual partners, high frequency of sexual activity, having new sexual partner every time, and early initiation of sexual intercourse is a common risk factor. Next. Risk factors of bacterial vaginosis are also seen in STIs. STIs are commonly sexually transmitted infections like trichomoniasis, and trichomoniasis is different than bacterial vaginosis because it is added infection of trichomonia in bacterial vaginosis. The cigarette smoking, obesity, being single or not married, prior pregnancy, history of induction of labor, frequent use of sexual toys, and if the toys are used by multiple partners, then if there's frequency of having digital sex or vaginal sex, frequency of use of scented soap, and it's also commonly seen in lesbians. Next. The protective mechanism which we can prevent bacterial vaginosis are abstinence, which is usually not seen in reproductive age group. The use of condoms is the better way for avoidance of it. Hormonal contraception, combined pills, or only progesterone pills can be used. Cleaning of the sex toys in between the use is very important. Clean it with soap or water is also enough. Use of gloves during digital and vaginal sex is very important because that digital transmission of bacterial vaginosis is very common. Use of probiotics.
This is again a controversial thing. Probiotics may help or may not help depending on the patient's conditions. Next. Etiology for that is bacterial vaginosis is common synergetic polymicrobial infection, which goes more on Gardnerella vaginae, is thought to be having a leading role in the infection. So associated bacterial infections are Prevotella, anaerobes like Mobilochus, bacteroids, Streptococcus, Fusobacterium, Veillonella, and Eubacterium. Mycoplasma hominis also seen at a times. Urea liticum is also seen. Then Streptococcus viridians is commonly seen. Atopobes vaginae is also one of the bacteria which is associated with bacterial vaginosis. Next. Pathophysiology, as you all know, we these are not exactly the pathogens. There's only altered flora of vagina which commonly give rise to bacterial vaginosis. So it is thought the result is also, as I said, shifting of a flora of lactobacillus to more diverse conditions will give rise to anaerobic infection like this. The shift of vaginal flora causes a reduction in hydrogen peroxide, which is present usually in lactobacilli, and this shift gives rise to change in vaginal pH, which becomes more on acidic side, more on a alkaline side. Sorry for that. And overgrowth of Gardnerella vaginalis and anaerobes is also seen with this. So decrease in pH facilitates the infection. So adherence of Gardnerella vaginalis to exfoliating epithelial cells is a clue to this, and formation of Gardnerella vaginalis biofilms which can survive hydrogen peroxide taste and lactic acid taste, and high levels of antibiotics has to be given followed by this. Next. Anaerobes produce large amount of proteolytic carboxylase enzymes which break down the vaginal peptides and gives rise to amines which are volatile, malodorous, gives a very bad smell, that is fishy smell, associated with vaginal transduction. Then production of amine causes reduction in lactobacilli, which leads to increase in vaginal pH. So anaerobes produce amines called as trimethylamine, and which gives rise to fishy smell. So anaerobes produce succinate, that is keto acid, and production of succinate and gives rise to absence of lactic acid, and which gives rise to polymorphonuclear leukocyte, reducing the killing of this leukocytes gives rise to inflammatory reaction, and this gives rise to the inflammation, and these patients are more prone to bacterial vaginosis. Next. The pathophysiology you all know. Whenever there is a loss of lactobacilli, there's a rise in pH, there's amine production, there's a growth of mobilucus associated encouraged growths of anaerobes. Rise in pH will cause loss of lactobacilli, and again the cycle goes round and round, and the growth of Gardnerella, which gives rise to pyruvate and amino acid production, and bacteriocytes metabolism gives rise to amine production, gives rise to rise of pH, and gives rise to loss of lactobacilli. Next. The clinical presentation is usually what we commonly see in our OPDs with bacterial vaginosis is vaginal discharge, which may be watery or which may be associated with fishy odor, and odor may be recognized only after sexual intercourse or without sexual intercourse. The alkalinity of semen may cause release of volatile amines, and which will give rise to more of a vaginal discharge and cause fishy odor. So increased vaginal discharge to a patient who is not yet married and having bacterial vaginosis may be thin, homogeneous, white or gray discharge. So vulval irritation is not usually seen with bacterial vaginosis. It is very, very less common. So dysuria and dyspareunia may occur post bacterial vaginosis. Next. The physical examination usually gives rise to the typical grayish thin homogeneous discharge, which is large in amount. Usually discharge is usually associated with vaginal mucosa. Then the small bubbles or the discharge may be associated with froth, and there's no pulling of a discharge in a posterior fornix. An increased light reflex of vaginal walls may be observed, indicating very wet appearance of the vagina in total. There is little evidence of inflammation in the vaginal wall, so reddishness is not there of vaginal wall. So labia, introitus, cervix, and cervical discharge is usually normal in bacterial vaginosis, and the cervicitis and additional sexually transmitted disease has to be kept in check, so that she is more prone to other STDs along with it. Next. So this is very important. Like, this is a bedside test of litmus paper, so that you know what is the exact pH of the vagina. So as we take the litmus paper, we used to do this in residency. In Kama Hospital, it was very common. The people used to come with bacterial vaginosis, and we had a cytology clinic there. So madam used to call us and ask us to do this litmus test. So we are very familiar with this test, and I still, till today, whenever the patient comes with bacterial vaginosis, I do at a times. If she comes second time to me, I do this litmus test. So it's very simple. As you all know, white is healthy, yellow and green is sexual transmitted infection or maybe trichomoniasis. If it is pink and red, she may be having cervical infection. So you have to treat this patient immediately and call her for the follow-up. If it is gray, then you not much to worry about. If she's not having irritation, she's not having itching, just counsel her, and having itching, then treat her. Then if it is a clear, it is a healthy ovulation pregnancy with hormonal imbalance. Thank you. Next. The differential diagnosis is usually of bacterial vaginosis is commonly seen as we come across with cross infections with bacterial vaginosis, like trichomoniasis, chlamydia infections, gonorrhea, and HPV, and etc. So differential diagnosis, as we all know, is candidiasis, cervicitis, chlamydial infection, gonorrhea, HPV, trichomoniasis, vaginal candidiasis, and vaginitis. Next. Vaginitis, if the pH is normal, as I already said, it's an abnormal pH. Normal pH is infectious and non-infectious. Then infectious, it goes to vulvovaginal candidiasis and HSV infection. If non-infectious, it goes to vulvodynia, dermatitis, and physiological leukorrhea. If it is abnormal pH, if it is infectious, it goes more in favor of bacterial vaginosis like trichomoniasis, along with the secondary infection of trichomonia and cervicitis. If it is abnormal pH, it's a non-infectious, you have to go for rest of the blood investigation to see if she is diabetic or she is having another cause along with it. Why the Zoom meeting is on?
Sorry to interrupt you.
I'm not able to
Time
see
is
myself.
up.
Oh, I'm just shifting now to my last two slides. The treatment, and thank you. Shreya, please continue if you can. Sadhana madam.
Ma'am, which slide you want, ma'am?
Treatment and thank you.
Hello. This
Yes.
one, ma'am?
Treatment, management.
Nilima, it is showing Zoom only. It's not showing slides. I think. I think Dr. Sucheta, you can sum up. Yes, you
Okay,
can
I'll
sum
sum
up.
up.
Yes,
I'll sum up. I know.
slide because it
See,
is only two slides.
if it is a bacterial vaginosis, if she is having irritation or all, you treat with metronidazole 500 milligram twice a day. Then, if it is trichomonal infection, you treat with metronidazole twice a day for or thrice a day for 7 days, or with metronidazole gel. Then, then when it is a chlamydia infection, you have to treat with clindamycin 500 milligram for 7 days. And if patient is not comfortable with taking tablets, you can give a clindamycin gel. Then I thank you all for making me to talk with you all and give this presentation to which is the commonest thing we come across. Thank you, Sadhna madam. Thank you, Kasturi madam. Thank you, Kanchan.
Thank you, Sucheta madam, for the excellent talk. It's a very everyday problem. So you
Ma'am,
have
you are
addressed it
logged in
well.
with two devices, ma'am.
Yes, yes.
Yeah.
I think
See,
that
going.
Dr. Anuradha Khanna ma'am was logged in into two. Yeah, I think there's no icon. Go ahead.
Thank you, Pratik.
Thank you, everybody. Let's proceed with the next speaker. We've already exceeded our time. Can we have the introduction of the next speaker, please?
Dr. Anuradha Khanna, may I request to introduce Dr. Rajeshri?
Anuradha ma'am?
They have just unmuted me.
Oh.
I welcome Dr. Rajeshri Katke to be speaker of this program. She's a renowned obstetrician gynecologist,
ma'am,
surgeon of excellence. And since you are that, you are welcome in this ICOG things. And I think everyone knows you very well, otherwise also, and we will listen you for your insight.
Yes,
Thank
yes.
you so much.
Thank you so much. Thank you. Can I share my screen?
Please go ahead.
Yes.
From beginning.
From beginning that time, sir. Yes, at the outset, I would like to thank Dr. Sheila Mane ma'am, Dr. Sadhna Gupta ma'am, and Dr. Pratik sir, Kanchan, and whole team of that. Today, I'm talking about the evidence-based management on PROM and PPROM. I don't go in detail, only practical things have been taken. What is a pre-labor rupture of membrane means fetal membrane rupture before the onset of labor of contractions. Preterm means PPROM means before 37 weeks of the gestation. It's not going. What happened? Yes. So basically, it increases the risk of obstetric complications such as the intraamniotic infection. That is the more worried point. And the second thing is that the clinician must balance the risk of pregnancy with the fetal risk of the maturity. Epidemiology, it is around 8% of the term pregnancy is going in that, and PPRM, it will goes the before 24 weeks is around 0.3 to 0.4% of the pregnancies. I don't want to go in detail of that. Only one important thing is that there are the fetal membranes, which is the amnion, and one is the chorion amnion inside, and both of them, they becomes one into the, they get adherent with the extracellular matrix in that. And whenever there is a term pregnancy is there, this weakens, and with the degradation of that, normal, there is initiation of the labor. But if it happens prematurely, then it comes with the preterm or premature rupture of the membrane. So basically, the inflammatory response is the one which is one of the cause of that and the infection. The cause comes, but basically there is a latency period with the effect of the injury, and the effect leads to the formation of the premature rupture of the membrane. So by the 12th week of the gestation, the fusion is strong yet flexible extracellular matrix, and this is the only one important thing that we can see even with the ultrasound afterwards also. The activation of the matrix, metalloproteinase, and the selective apoptosis, that causes the weakening of the membranes in this.
So, what is the required antenatally to identify the infection is that a combination of clinical assessment and the maternal blood test, which is very important, C-reactive protein and the white cell counts in that. So, in etiology, either it could be infections, normal weakening of the physiological weakening of the membranes, intrahepatic pressures, and the oxidative stress. Oxidative stress is very important, maybe because of the oxygen, the reactive oxygen species, or non-infectious causes like tobacco use, less of antioxidants, and the phytoplacental energy demands. That is the one which we are more worried about how to tackle with that. So risk factors, I just tell us with that, if there is a history of PROM, short cervical length, amniocentesis, uterine overdistension, connective tissue disorders, or the congenital uterine anomalies like that. So how to approach toward the history and the physical? So basically patient will present with, there will be a significant amount of the watery discharge use that. Then we can ask about the color, odor of that, whether it is associated with the blood or not, or there is a vaginal pull of the fluid. That is one of the thing which it demonstrates the volume of the fluid loss in that. And if it is associated with the pain or the recent sexual intercourse or the trauma. So these are the things we should ask in that. Sterile speculum examination, direct observation of the fluid of the leakage, pulling, which refers to the rapid collection into the of the amniotic fluid. Ask about the Valsalva or cuff to provide the fluid leakage in that, but don't do a vigorous digital examination to see the dilatation and effacement of that or the station of the head. That may release that. One is that it introduces the infection, and the second thing is that it can give rise to the release of the prostaglandin in that. So intrauterine infection, if it happens, one should look for the maternal fever, fetal tachycardia, maternal tachycardia, and false smelling discharge in that. So how to confirm the diagnosis of the rupture of membranes? One is a direct history, direct visualization of the fluid of the leakage, microscopy, where there is a furning pattern, but this furning pattern is different from the furning pattern of spin-Bargett phenomenon, which is very thickened and the broad lines are there. So that is of the cervical mucus, and this will be a thin branches you can see in that. Vaginal fluid pH testing, one can do alkaline, means amniotic fluid has a 7 to 7.4, and a vaginal secretion of the pregnancy have a pH between 3 to 4.5. So there are false positive pH tests, sometimes it is contaminated with the blood or semen or the bacterial vaginosis. The false negative will come whenever there is a prolonged rupture of membranes or the minimum leakage is there, it gets contaminated with the vaginal secretions and all. Diagnostic test of the amniotic fluid proteins. These are the things which we are looking about this when there is a high leak is there or small amount of this thing in a preterm around 24 to 34 weeks of this. These factors are very important, like insulin like growth factor, binding proteins, and the combination of the IgFBA with the alpha protein. That gives the most of the idea about the where there is a leakage is there or not. How is the diagnosis of the PROM mode? So basically a spontaneous rupture, clinical, I have just explained to that. These are the green top guidelines, even they go the same with what we say in that with the clinical. The role of the ultrasound assessment of the amniotic fluid is of the volume is unclear, but in practice we see that gives the idea about this thing. So let's skip. Group B, beta streptococcus. This is the very important thing. If suppose we get infection like that, then it should be treated by giving the prophylaxis antibiotic for that, or doing any cultures from the rectovaginal septum or the vaginal secretions. Dye test, we don't do that because it is quite invasive, and tampon test, we don't do it in that, but additional diagnostic studies we can do with diagnosis of that, but we have to do for the evaluation of the fetal well-being with the and the obstetric ultrasound. These are the two important things one look for that. Urine examination is very important to rule out any infection into the urine, or there is any urinary incontinence episodes are there that may mimic like patient may mimic like that there is a lot of fluid coming it out. So white blood cell WBC count more than 15,000. We can say even more, it crosses more than 10,000 also. We can see if there is any focus of the infection is there or not in that. So maternal serum markers of predicting histological chorioamnitis after PRM. Conclusively raised C-reactive protein was most informative. So people, they are going toward the C-reactive protein, which has a sensitivity of 68.7%, but specificity of the 77.1% in diagnosing the PPRM. So how to go with the evidence-based in the management? Suppose she is 37 weeks and there is a leak is there. You don't have to do anything for that. Give the prophylactic antibiotic for that and go for the delivery of the patients in that. Don't use intracervical catheters because it should be avoided because it will introduce more amount of the infection in that. So amongst the oxytocin and what is the role of the prostaglandins, that is one thing is that. But for the cervical ripening, if there is a poor Bishop score is there in the posterior fornix also, we can put with the cerviprime gel and that can give rise to the effacement of this thing. If we are going to do the induction of labor in that, oxytocin is definitely, it is one of the important thing, but it depends upon the Bishop score. So, but suppose the management approach in a preterm patients like 36 before 37 weeks means 36 or 34 to 36 weeks. If you want to prolong the things, then you should give a single course of the corticosteroids. It is recommended for all patients to give the lung maturity of the fetus in that. So whenever there is a GBS positive is there, group beta streptococcus, then you should go for the, and you want to do a expected management, go for a good antibiotics, give a cover of the corticosteroids for that, and you can pull with close monitoring with the expectant management, and worldwide they are saying the good results with that also. But at the same time, you have to think if there is any sign or symptoms of the intraamniotic infection, then you should go for the termination of the pregnancy. So fetal well-being is typically monitored, that I have already explained to that. But the leukocytosis and the C-reactive protein, if it is persistingly with the rising trends, then it is then it gives the idea about if there is an intraamniotic infection is there or not in that. So these are the things till the 34 weeks, but we are more worried about the, because we are having a lots of good NICU setups in that. So early preterm, which is from 24 to 33 weeks of gestation, where we want that expected management is recommended when no maternal or fetal contraindications are there. In such cases, you can go with the corticosteroids and you can give the, for the neuroprotective, we can use the intrapartum magnesium sulfate for the fetal neuroprotection. So latency and latency antibiotics have been shown to prolong pregnancy in some patient, in most of the patients with the PPRM. So we can give like ampicillin. Some people they give for the, we don't give much of the erythromycin and all, and amoxicillin we can use, or if there is signs of infection, we can go with the azithromycin or the broad spectrum depending upon the individualized case in that. Should antibiotics to be given? Yes, definitely we should give the antibiotics. Mainly this says for the 10 days and all, but 7 days, because Cochrane review has been found the antibiotics were administered, there is a less chances of going into the chorioamnionitis, and that is very important. What is the low role of the antenatal corticosteroids? Definitely there is a role of the corticosteroids. When you have a expectant management in cases of the preterm before 34 weeks of that, and then you can go with the betamethasone will be the best one in that. Use of tocolitis in patient of the preterm PRM is controversial. Some people they says you should not use. Some people they says if it is near to deliver in it within 24 to 48 hours, then to quieten the uterus. But it is controversial role in that. But with the green top guidelines, they says we should not use the tocolitis. The crucial thing for the obstetrician is that whenever there is a pre-viable and the peri-viable periods, means 24 to 29 to 29 to 32 weeks. In that, we feel that you should go for the expected management. It can be considered in the absence of the contraindications or in the problems. If suppose she develops chorioamnitis, there is placental abruption is there, infection is there, non-assuring fetal status is there, then you should go for the termination. But this contraindication, if it is not there, then giving cover with the antibiotic and you can say with the judicial use of the corticosteroids and the magnesium sulfate, you can pull tears towards 3 to 4 weeks, to get the baby maturity. So should neonatologists be involved in the women's care? Definitely. There is no point of you should have a very good NICU for that, for these all premature, very premature, preterm babies for that. What is the role of magnesium sulfate for the neuroprotection of the baby? Definitely there is a role of the for the neuroprotection. You can give 4 gram IV slowly till 15 to 20 minutes in that. You can repeat 1 gram after that also, but it should be offered between 24 to 29 weeks of the gestation in that. Should tocolytic agents use? Tocolysis in patients with PRN is not recommended because Cochrane view, they come up with the Cochrane review and they don't come with the this can sorry, there was a patient in OT, so they were calling me. Can women be monitored at home? Definitely for us, we don't keep such women in a home and all, but it should be individualized on the cases, how educated and how much they have the things in that. Is there a role of amnio infusion in PRM? These also, there are the various worldwide, we have gone to the literatures and some people, they says amnio infusion is not recommended as part of the routine clinical practice, but you feel that there is a thick meconium is there, or sometimes if you want to use very, in rare cases, people has done very small studies and still they says the use is, whether to use or whether not to use, they have not given the things they have said ki it depends upon your experience and the individualized cases. Should women with the PPRM be offered emotional support? Definitely, because here we are dealing with the premature, again, either infection, stress, post-traumatic stress, and even the baby is premature and the complications of the baby. So definitely emotional support with the counseling and taking consent is very important in that. Sometimes we take a preterm premature baby, there is a lots of in lakhs of the bill for that in the NICU and all, and the baby doesn't get survived, then it becomes a very difficult thing. And sometimes to give the answer into the inquiries also becomes difficult. When is the appropriate time to deliver the baby? So basically, whenever there is ideally we always go for more than 34 weeks, 37 is very good, but period of 24 to 34 is the crucial one to take the decision for that. Care in a subsequent pregnancy following PROM. Mine is not there. Who should care for the woman in a subsequent pregnancy? Definitely, the obstetrician has to take care of if there is a previous thing is that. Fetal membrane healing is very important. The concept has come after the amniocentesis, there has to be a sealing of the membrane. So what they say is that in a skin, because we have the fetal membranes are not innervated and very poor supply. So wound healing response includes that inflammatory formation and tissue regeneration is not as like as in the skin. So that is the point where we are where the research is for the sealant of the membranes in that. So there are some interesting studies in a fetal membrane healing in vitro. They have found some cell monolayers that are obtained from an amnion derived cell line, and that they says ki there is the possibility of healing in that. Use of tissue sealants in vitro in fetal membranes. This is the research one. Fibrin glue, they have been used as a sealant in vitro wounded with the fetal membranes in that. Because sometimes you do a puncture in the membrane. So what it happens with that puncture, they have tried to put with the fibrin glue in that and it has been sealed with this. So in some cases, the sealing has been done with the platelet rich plasma and the fibrins. And that has been some studies I have found in that case. So they have sealed those points even in vivo also with doing fetoscopy and all. So NDAG laser is the future, what they are thinking in that, and use of tissue sealants in vivo in human fetal membranes where the fibrinogen solution, it can be used with the double jet double syringe and you can seal those points. What is your point? Our point is that whenever there is a rupture of membrane is there is some point where there is a hole is there, high leak is there, and that drains the fluid and that amniotic
Sorry
fluid.
to interrupt you, ma'am. Your time is up.
Okay, 1 minute. I have finished all the things. Only I would like to say, yeah, consultation, coordination between obstetric and pediatric services is very important. Enhancing healthcare is very important. Nurses' role is important. This slide I would like to say with 1 minute. Recommendation for future research is the antibiotic of choice, magnesium sulfate, how it is useful, and the role of sealants to repair the fetal membranes in that. Auditable topics are proportion of women with PRM who afford the antibiotics for 10 days or until. The woman is having the established role of steroids, and these are the auditable topics and my references. And I would like to end my talk with the innovation is seeing what everybody has seen and thinking what nobody has thought of. Thank you very much for the patient hearing, giving me the opportunity. With this, I'll stop share of this thing of mine.
Then we
Yes.
have closing remarks from our chairperson.
Sorry. I couldn't see. It was, I have not taken much time, na?
Dr. Anuradha ma'am and Dr. Kasturi, your comments, concluding comments.
Excellent talk.
Thank you.
Very nice and very practical, and especially for the preterm PRO, it makes so much difference to do all this, and then especially preterm around 10, 30 weeks, 20 weeks. So conservative management with close monitoring, as you told, is very, very important. It makes a huge difference for the baby's survival. And as you told, counseling and correct consent is important when we do those things. And thank you. Excellent talk. Very practical oriented talk.
One thing to Rajeshi, just we are running short of time. There is a 2 points which is in ground realities. One is the GBS. The NICE says always, but our own data says that we are not having GBS, we are more having the E. coli. So GBS screening, I think it is not being done in most of the clinical practice. And the second is use of erythromycin. So
we are not using that.
And everybody said we don't like erythromycin. So this is the time that we actually say robustly our clinicians are not liking our data, whatever AIMS study says that GBS is not, it is E. coli in our population. So this is a few points that erythromycin is not a drug of choice for the Indian obstetrician. What's your comment? And Dr. Radha
No, I'm right. It is very right in that, but sometimes we are giving rampantly antibiotics. Couple of patients of mine responded to erythromycin than the cephalosporin. That is one thing. And second, I would like to say that there are some cases who also comes for the GBS, though we are having the E. coli in that. Sometimes rectovaginal leakage is there, anal fecal incontinence, close vicinity of that. So everything has its own. I feel the culture should be, swap culture should be taken it of that, and with that we can treat if in some cases of that.
मैडम अनम्यूट कीजिएगा डॉक्टर राधा खन्ना अनम्यूट करिए अनुराधा खन्ना इज
I've
नॉट
sent her a request. I've sent madam a request.
मैडम का शायद कोई आई थिंक नेटवर्क इशू.
Okay, I've been admitted. Till now I was muted. So both the talks were very nice. As the second talk, I would like to say very nicely, very elaborately given by Dr. Rajeshri, and everything was very important. Depending on the time of rupture membrane, the management should be done. She has well explained about the magnesium sulfate and antibiotic covered. And in first talk also, there was a bacterial vaginosis concern. What I'm seeing nowadays, that our seniors, juniors, all, they are not getting a PS examination done. Even with the complaints, that is the most important thing. Everyone is jumping for ultrasound. But now seeing the PS examination, if you do PS examination with patient is having complaint, actually no need of doing litmus paper. You will get the amine smell and you will diagnose immediately. How, I don't know how many of us are using litmus paper. So a proper clinical history and proper clinical examination is the best thing, seeing the discharge type. And if you want, you can wait a wet smear. But I don't know, so many practitioners I know, hardly they are doing it. That's not the practical. In medical colleges, yes, I was also doing it, but not now. I'm telling you my truth, what I'm doing. Then, so this is about the vaginosis. That aspect was not discussed about the management in the BV. So we all know about metronidazole. But if it is recurrent BV, we have to find out what is the etiopathogenesis, and also it is genetically connected. The obesity is one of them. But of course, diabetes is also there. The frequency and type of partners, they are there. But genetic concern is also there in both the cases of PV and also in PPRO.
Ma'am, you are muted. You have to unmute, ma'am.
Yes. So these are the few aspects, and we have got, there is much more to say, but we are having short of time, so I'm not prolonging. But I will request all my seniors and juniors, please go for a precise history and examination. Thank you so much.
Thank
And
you.
Just
Dr. Sadhana Gupta.
one additional point. I
Yes,
think
Dr. Sheila.
there was a study where they said every patient coming to labor room, whether PR or MP, just to give 2 grams of azithromycin to reduce the incidence of intranatal as well as the neonatal infections. So that is also one of the prophylactic way, because most of the time the patients have a bad hygiene and then they just walk in and that is not followed. So there is a study, if we give 2 gram azithromycin to every patient who walks in labor room, we can prevent so many infections, because today
One
we
of
are
the theses done under me,
Yes.
in which we
Yes,
have
great.
every month, not only oral, every month local application of clindamycin and trimoxazole. That has also covered every month, though she has history of PPRM or she is having then, and also oral metronidazole I give 400 BD for 5 days if after 16 weeks of pregnancy. No
Azithromycin
harm.
has a very good results.
Yeah, azithromycin definitely.
And it is included in all the worldwide guidelines also in that.
Yes, yes, yes.
Shobha Gudi has raised her hand.
Since we are running late, can we proceed to
Yes.
the next session?
Yes, yes.
Yes, sir. Yes, sir. Thank you so much, Sucheta ma'am and Rasri ma'am for excellent talk. And thank you, Anuradha ma'am and Kasturi ma'am for great inputs. And now we can move to the next session. And for next session, we have 3 very learned chairpersons. Dr. Haresh Doshi sir, Dr. Sobha Gudi ma'am, and Dr. Amrita Japuriyar madam. And we all know Haresh Doshi sir. He is a renowned person, and he is currently professor and HOD of.
Okay. We are running late.
Thank you. Welcome you, sir. And we
This
all
line
know.
is not correct. I'm not contesting.
Well, I welcome you, sir. And we have Sobha Gudi ma'am.
You can contest again. We are happy to have you.
Yeah, we will support you, Dr. Doshi. No problem. Come.
No, thank you. No, thank you, madam. Thank you. Over.
Yeah.
20 overs. Over. 20 overs.
Kanchan, it is quite okay, Kanchan. It is quite okay.
Last word by Dr. Sheila Mane.
Ma'am, you
have gone mute. You've gone mute. Your last word was not heard.
You are muted.
ICOGN.
ICOGN, yeah. Yeah.
we
Yeah,
all
we
know
can
Sobha Gudi
proceed.
ma'am. I welcome you, ma'am. And
Thank you.
I welcome Dr. Amrita ma'am, Amrita Japuriyar ma'am. Very
Thank
dynamic.
you. Thank you.
Hand over the
You
session.
know, Sheila and Pratik, it is like somebody inviting us into our own house. It has become like that.
We're all
Thank
family
you.
members.
Thank you. Yeah. Thank you. Dr. Doshi, you can introduce the first, Harish
I
bhai.
request Haresh Doshi sir to introduce speaker Saroj Singh madam. Can we have the CV of Saroj ma'am?
Yes, thank you. First,
Neelam?
I must thank ICOG officers, Dr. Sheila madam, Sadhana madam, Ashok Kumar, Pratik, and FOGSI office bearers Bhaskar and Suvarna madam for inviting me as a chairperson. It's very important. FOGSI ICOG infection certificate course. Infection. Saroj madam is a very senior faculty HOD, principal SN Medical College, Agra. She had many positions as president, UPCOG, UPSC, Agra Visual Society, and chief editor of Journal of UPCOG.
Thank you so much.
And more than 150 research papers and more than 40 years of experience. And she has many awards to her credit, right? Many undergraduate medals, gold medals, and also Naval Kishore postgraduate medal, FOGSI Star Award, FOGSI Luminary Award, Woman of the Best Woman of the Year Award, whatnot. Very great faculty. Madam, welcome to this.
Thank you so much, sir. Nilima, can I share my screen?
Please go ahead, ma'am.
Yes, ma'am.
Nilima ji, can I share my screen?
Yes, please.
Before I start, I thank our chairperson, Dr. Sheila Mane ma'am, Dr. Sadhana Gupta, Dr. Pratik Tambe for giving me this opportunity. And I thank the chairpersons, Dr. Harish Doshi, Dr. Shobha Gudi, and Amrita. So after listening about the infection during pregnancy, let us come to the puerperium. And puerperal sepsis I will be discussing. We all know that puerperal sepsis remains a critical public health issue because, especially in low resource setting like ours, because it is a significant contributor of maternal mortality and morbidity also. So let us first understand the terms very clearly. We all know that puerperium is 6 weeks after delivery and where all the pelvic organs are reverting back, and sepsis, it has already been discussed that this body's response to infection where the infection which causes injury to its own tissues. And puerperal pyrexia we have to understand, and then puerperal sepsis separately. Pyrexia is when temperature of more than 100.4 degree on 2 occasions from day 2 to 10. Because first day is not taken because in first 24 hours there can be transient pyrexia because of the physiological strain of the labor. But it can be because of many reasons. Maybe because of pelvic infections, maybe because of breast lesion, mastitis, engorged breast, UTI, and or infection in the other parts like tooth sepsis, malaria, etc. But puerperal sepsis is the infection of genital tract only. Infection, WHO is clearly defined by infection of genital tract between rupture of membrane or onset of labor to 42nd day when any two of these following symptoms are present, either fever of more than 100.4 or abnormal discharge or abnormal smell of discharge, or pelvic pain or delay in involution, which we call it subinvolution. Because it is affecting both from the labor to delivery to postpartum period. That's why the better term which now WHO has suggested is peripartum sepsis instead of puerperal sepsis. If we go back to the history, the condition is known years back since 5th century when it was considered as a serious complication of childbirth, but reason was not known. It was thought that it is local putrefaction but the term puerperal fever came only in the existence in 1716. And great work was done by the Semmelweis of Vienna, who insisted on washing of hands, which is still persists and which is very important nowadays also. And then came all the things of antisepsis and Louis Pasteur's work, which we all know. But if we take history of our country only, the puerperal sepsis was known even before that, even before Hippocrates. It was known as Makala, and it has been described in Sushrut Samhita also, which was in 6th century. He described very nicely that parturient should be isolated for at least 40 days. And even its management, that how daily bath and so many things on the Ayurveda has already been described. Even in Charak Samhita, the art of asepsis is there. So we have to look to our history also. We all know that it has already been discussed that sepsis, puerperal sepsis is an important cause, causing 15% of death, which has decreased now to nearly 11 or 12%. Maybe because of improved personal hygiene and or better obstetric care and potent antibiotics, which we all are using. But this infection is 5 to 10 times higher when it is cesarean delivery. And the incidence differ greatly in low resource setting and countries like USA, where it is very less in 0.04% of deliveries, but accounting for 23% of maternal death because their MMR is very low. But we have again to understand that the majority of these deaths are preventable. And after each this death, nearly 50 women are having life-threatening infection, which is near miss maternal death. So early recognition, expedient evaluation, and appropriate management is very, very essential for maternal sepsis. This we all know that vaginal flora is, which we all know, but during pregnancy, at the end of time of delivery, even Candida albicans may be in the vaginal flora because of the acidic pH. But these organisms are lying dormant and they are harmless. If aseptic precautions are taken and delivery is conducted, they do nothing, no harm. But if infection occurs because of so many reasons, and the reason main is that placental site is the lacerated wound, or there can be lacerated wound in the vagina or perineum because of the tears which have occurred. If those get infected, and on above that, the devitalized tissue, blood clots, etc., add on for the which increases the microbial growth. Maybe that this growth may remain localized, or it may spread to the surrounding structures, or even it may reach up to the blood stream. So from where this infection has come? The infection, it may be that it has the endogenous from the organs where it was already present, or it may be from the other parts of the bodies like boils, sore throat, teeth, etc. Or it may be from the other persons who are coming and causing, or maybe infected instrument or something like that. But infection may remain grade 1 when it is only endometritis, or it may increase to endomyometritis or pelvic cellulitis, or it may reach to the blood also. So the severity vary, and it depend on the organism also. If we see the organisms which are responsible, we all know the most difficult or most organism is group A, hemolytic streptococci, which is very dangerous and it causes toxic shock syndrome and necrotizing fasciitis many times. But this Staph aureus is very important, and especially this one, methicillin resistant Staph aureus. Then even gram-negative infections may be there, anaerobes can be there. But many of the time, these infections are polymicrobial, mixture of aerobic and anaerobic, and accordingly we have to manage them because it is the mixed infection. So who are the ones who are more prone for this puerperal sepsis? Those who are malnourished, those who are anemic, obese, uncontrolled diabetics, or immunocompromised, those who had lack of antenatal care, even intercourse in the late pregnancy, that also increases the chances of infection. Then all this during labor that we have seen very well, it has been discussed in detail. Even intrauterine fetal monitoring, if it is invasive one, that increases. Then even during delivery, that the cesarean delivery, operative vaginal delivery, or even if hemostasis has not been properly taken, all this increases the chances of infection. And it may be very mild, or it may be so severe, leading to cellulitis or salpingitis or pelvic abscess or septic pelvic thrombophlebitis, or even sometimes septicemia, shock, and death. Or it may be that the infection has been controlled, but later on it can lead to infertility or TO abscess or ectopic pregnancy like that. So we have to be very alert. And if we can prevent, that is the best one. We all know that prevention is definitely better. So during antenatal period, we should treat anemia so that at the time of delivery, their anemia is treated, their diabetes is controlled. There is no septic focus anywhere on the body that we have to take care of, and prophylactic antibiotics, which has been discussed in previous lectures in detail. Then even in intranatal period, that has been discussed, the aseptic precautions. We all know that the 5 C's in even an NHM guidelines, right from for many years, clean surface, clean instruments, clean cord, we have been taking care of this for many years, and that has to be carefully taken care of. Then prophylactic antibiotics, even during intranatal period, even in postnatal period, the personal hygiene, the sterile pads, minimizing visitors. Yes, that is also very important. The number of visitors with taking their shoes outside the room, all these things matter a lot. But if we cannot control, if a sepsis occur, then we diagnose it by the fever, chills and rigors, lower abdominal pain, nausea, vomiting, and many times subinvolution leading to the soft, tender, subinvoluted uterus, and these things comes, and foul smelling discharge. And it may be sometimes that it may be associated with deep vein thrombosis, for which we have to look for the calf tenderness, etc. Then these are just telling on which day fever is occurring, that will suggest that what is the cause. Puerperal pyrexia can be because of many reasons. So endometritis, usually it is start on day 2 or 3. Although deep vein thrombosis, when it is occurring, it is a little later. So that accordingly, we have to think what is the cause. So what exactly we have to investigate in these cases? Mainly, we have to see what is the site of infection in our case, what is the causative organism, and how much is the severity, because accordingly we'll manage. So the routine investigation, urine culture and high vaginal swab culture and blood culture, especially at the time of peak of chills and rigors, we take this. Ultrasound mainly to exclude pelvic abscess or retained pieces. Yes, if it is there, we have. Color Doppler in cases if we are suspecting DVT or septic pelvic thrombophlebitis. And then, of course, viral markers to see whether it is immunocompromised or not. Then malaria, etc., we have to exclude. and CT MRI only when we are suspecting this peritonitis or septic pelvic thrombophlebitis. And in severe cases, of course, we need LFT, KFT, and lactate also to be done in these cases. When we manage these cases, we have to measure the vital signs, because those cases who are mild, we can start with them with the oral antibiotics and start with the oral fluids and the presence of, if there is the presence of retained bits, that of course we have to evacuate and take them out, and they should be monitored nicely. But those cases who are having tachycardia right from the beginning, high-grade fever, of course, these are the cases who need IV antibiotics, and then they need admission to the hospital. So whenever we are admitting these cases to the hospital, we have to consider them as the obstetric emergency, because we have to start treatment very rapidly. And the antibiotic has to be started, broad spectrum antibiotic has to be started within 1 hour of the admission in these cases, because we have to limit the sepsis to keep it localized. Of course, isolation, then this diet rich in vitamins, because we have to promote their healing also. Fluid electrolytes, oral fluid tablet, all these things we give for them. If they are anemic, definitely we have to give them blood transfusion also. Baby, if mother is severely ill, definitely baby has to be kept separately. But otherwise, in mild cases, it can be with mother, but we have to prevent neonatal infection in these cases. We have to monitor these cases on pulse, BP, temperature. Vaginal bleeding, of course, we have to see that it is not foul smelling. And involution, we have to measure daily, and we have to exclude that there is no deep vein thrombosis. Antimicrobial therapy, definitely that is the most important thing initially, because culture report is not there. So we start with the broad spectrum antibiotic, but it has to be started within 1 hour. It is so important that even in government EMOG guidelines, it has been clearly said, even at PHCs, intravenous antibiotic has to be started even on suspicion of recurrent sepsis. And on the parenteral antibiotics are preferred. According to WHO, the gold standard is the clindamycin and gentamicin combination. And if patient is not improving on that also, we may need to add ampicillin if we are suspecting enterococcal infection. The other regime is the combination of ampicillin, gentamicin, and metronidazole, because we know it is the combined infection. So we have to cover gram-positive, negative, and anaerobic, all type of infection. There are other alternatives also, like ceftriaxone and metronidazole, or penicillin, gentamicin, and metronidazole, because we have to see the spectrum and then decide get all the gram-positive, negative, and clindamycin, and this anaerobes have to be covered. Serious cases may have to be started with piperacillin and tazobactam, or those having which are the methicillin-resistant Staph aureus, then they may need vancomycin or teicoplanin. Then these cases are definitely monitored according to the Mayo's observation chart. And if when culture report comes, we may need to change antibiotic or upgrade depending on the sensitivity, or if there is no response in 72 hours, or if toxicity develops, we continue the antibiotics till the fever disappears 48 hours after that. And if patient is controlled, we may switch over to the oral antibiotics. But these cases need to be monitored very carefully. And serious cases need to be monitored for serum creatinine and lactate also, because we have to exclude the renal toxicity and lactate if she is going towards the severity. So for escalation for the treatment, if there is hypotension, that is showing that she is going towards shock, hypothermia or tachypnea, or SpO2 is decreasing, or reduced urinary output, or serum lactate more than 4, that we have to take care of. Now coming to the separate type of cases who are just having something inside, septic focus is there, placental pieces or membranous pieces are inside, that is the focus which is leading to infection. That ultrasound, we know it, and it has to be evacuated gently, because uterus is quite big. There are chances of perforation or there, because we have to be very careful. So senior person has to do it under antibiotic cover, and it can be evacuated, and then infection will definitely decrease. Sometimes our wound may become dehiscent because of episiotomy, or our Caesar stitch line may become infected, and wherever there is collection, we remove that stitch, drain it, and accordingly we give the treatment, and may need to change over to the higher antibiotics. If it is very big, then of course debridement of the necrotic and healthy, we may need to resuture these cases. Sometimes severe infection may lead to just 2 minutes more infected fluid in the pouch of Douglas, and that which we see, and these cases present with the higher grade fever, and they may need colpotomy under anesthesia, preferably under ultrasound guidance. But then colpotomy has to be drained properly so that infection should not remain there. Sometimes pelvic cellulitis may continue, and that indurated mass there may remain there and may result into paralytic ileus or peritonitis also. Yes, we all have faced paralytic ileus in our cases of post-cesarean. Then, of course, electrolyte correction, early ambulation, and these all. Usually it dissolves, but sometimes it may continue to pelvic peritonitis, and these cases need nasogastric compression in the form of rice tube, or sometimes we may need to do laparotomy also if collection is there and it is not responding. And after doing that, we have to put drain. And sometimes in severe cases, we have to do hysterectomy when it is gangrenous uterus or rupture is there along with the infection, or there are so many conditions, or there is associated bowel or bladder injury. In these cases, may need hysterectomy, but that is quite rare. The septic pelvic thrombophlebitis will be discussed with the other persons this is in next month, so I may skip this slide. But these cases need IV heparin for their management. Necrotizing fasciitis, sometimes this is very serious complication of group A beta streptococci. It may affect the wound, the cesarean wound or episiotomy wound, and tissue necrosis occur because it is the M protein and lipotactic acid of the beta, this streptococci, which may cause necrosis all over. And this serious condition may need debridement of all tissue and very high broad spectrum antibiotic. Rarely endotoxic shock, which we will discuss in the future lectures. Then septicemia sometimes may cause the multi-organ failures. So just at the end, I want to say that puerperal sepsis is a life-threatening but preventable complication. We all do our best to prevent it by all health education programs, to encourage preventable measures by ourselves, by our PGs, by our paramedical staff, and by society also for the prevention. Prophylactic antibiotic for high-risk cases are required. Institutional deliveries, yes, this is a government order also that even institutional delivery, patient should stay in the hospital at least for 72 hours after normal delivery and 5 days after cesarean delivery, so that infection doesn't occur when they go home. Then special care and early recognition of high-risk cases and their prompt management is required. Complicated cases definitely need HDU or ICU transfer and multidisciplinary management. Teamwork can definitely save these young women from clutches of death. And if we all work together, definitely we can prevent many of them or cure many of them and save them. Thank you so much.
Thank you, ma'am. Shubha ma'am, you can go ahead.
आप कर दो, नहीं तो इंट्रोड्यूस आप करेंगे.
Introduce Karen. Okay, ma'am.
One thing which I wanted to say.
Fantastic presentation.
Yeah.
There are a lot of questions in the chat box. If you can take them there, please.
Yes, definitely.
Yeah, we will take it at the end of the second talk, Pratik.
Yes.
No, let her answer them in the chat box itself rather than.
Yeah, that is fine.
Okay.
And is Dr. Doshi there to conclude on this particular talk?
I think he has some audiovisual issues.
Okay,
No
so
worries,
I
please go
just
ahead.
wanted to add here. Saroj madam, that whenever women are quite sick with puerperal sepsis, we encourage the maintenance of a Q-SOFA score, and we treat them in HDU. And usually antibiotic escalation should be a policy, and has to be, the blood cultures have to be looked at. Becomes a multidisciplinary game actually. And very, very, very quick steps to improve hydration and escalation of antibiotics will save her. So the quick SOFA score is the pulse rate of the woman, the oxygen saturation, and the mental status. And it is scored as 0, 1, 2. I think everyone knows today how to maintain quick. So in addition to the other vitals, it's important to maintain an early Q-SOFA score. So it gives us early deterioration, and many times the clinical deterioration indicates that antibiotic escalation has to be done. But it was a very comprehensive talk, Saroj Singh madam. Thank you very much. And over to Amrita to introduce the next speaker.
Okay. Thank you, Saroj ma'am, for a wonderful talk. And at the outset, I would like to thank the ICOG office bearers for giving me the opportunity to chair and introduce a very brilliant, bright, and sweet speaker, Professor Binu Kushwaha Singh. She has been the former HOD, SS Medical College, Rewa. Presently, she is the Director Regulation and Policy, Director Nursing and Allied Health Sciences, Department of Public Health and Medical Education, MP. She is achiever of many awards and medals right from her MBBS days, Best Student, Best Paper, Corion Award, and so many. She has many publications to her credit. She has also achieved CRC Research Award. And so, Dr. Veenu,
Thank
as
you,
you
ma'am.
are,
Thank you so
so
much for
over
your
to
kind
you
words of
for the
introduction.
presentation.
Thank you so much, ma'am. I feel so much privileged to be surrounded by so many, I would say, stalwarts of FOGSI. We are all very
जी
well
थोड़ा
known
सा
to us.
कैमरा ठीक कर लीजिए, आपका पूरा
Okay.
चेहरा नहीं दिख रहा.
Is it okay, ma'am?
Yeah.
Good
Thank you.
evening, ma'am. Good evening to all. So I would just go through my slides quickly. Actually, I have to go for a meeting. So,
Yeah, no problem. Just press.
yeah, I'll do it only in like 5 to 8 minutes because Saroj Singh ma'am has already covered so many points there. I hope I'm like my slides are visible now.
Not yet.
Not yet.
Not yet.
Just a second. No, ma'am, there is something that.
Yeah, you have to click on this green button. Yeah, you are sharing. Yes, yes.
Yeah.
You need to share your PowerPoint window.
Yes, yes.
I think you've shared the browser now.
Yes. I hope it's visible now.
Yeah, please go ahead.
Yes.
Just make it slideshow. Yeah, good. Very good.
So the topic for my talk is septic thrombophlebitis. That is red alert for all. That should be red alert for all of us. So in next few slides, we would be trying to understand a rare but serious postpartum complication that requires prompt recognition and aggressive treatment. So septic thrombophlebitis is characterized by venous thrombosis with associated bacterial and or fungal infection, which may affect both superficial and deep veins. But when we talk in obstetric context, it is almost always it happens in postpartum period due to hypercoagulable state of pregnancy. So septic pelvic thrombophlebitis, it is called actually when it happens during postpartum period because it is a pelvic veins which are almost always involved. It's a very rare yet important cause of puerperal fever and even septic shock and death. So it has been for years called as the cause of an enigmatic fever. So what is SPT, septic pelvic thrombophlebitis? As I said, characterized by infection and clot formation in pelvic veins. But the challenge here is that we would not know this problem if we do not suspect it. It basically presents with persistent fever, which would be unresponsive to antibiotics. And this is the reason that it has been called as enigmatic fever due to its elusive diagnosis. So what are the odds? Who are at risk? If we talk about the general obstetric population, it is like its incidence is 1 in 2,000 to 3,000 deliveries in general obstetric patients. But the incidence is almost 20 times higher after the cesarean delivery. So in cesarean delivery, the incidence is 1 in 400 to 800 cases, while in vaginal delivery, it is 1 in 9,000 cases. So it is actually a ghost from the past, which we have won over. So if we talk about the history, it was first described in late 1800s. So SPT was then associated with devastatingly high mortality rates that terrified medical communities. And the treatment then consisted of even surgical practices with pelvic vein ligation being the primary treatment, even if the associated risk was involved of open surgery. But the incidence has decreased significantly now due to advancements in antibiotics and modern diagnostic imaging techniques. So the cascade of infection, if we talk about the pathophysiology of SPT, then the infection is initiated when there is a bacterial infection occurs at the time of placental implantation site or uterine incision after delivery. That is why we do not support this manual removal of placenta during cesarean delivery, because it is a source of infection. Then there is a phase of venous extension. So the infection spreads along the venous roots, causing inflammation and damaging the vein walls. Then, because of the hypercoagulable state of the pregnancy, it all leads to the clot formation in pelvic veins, and most commonly the ovarian veins, and that too right ovarian vein involvement is much more common than the left ovarian vein. So it ultimately in 25% of cases, that is very high. In one fourth of the cases, the clot extends into the inferior vena cava, increasing the severity of the problem if we do not intervene on time. So how would the patient present? First, the most common symptom is hectic fever spikes. So persistent fever and chills continue despite antimicrobial, the routine antimicrobial therapy for postpartum endometritis. Then there may be localized pain, and most of the time tenderness is there, especially in right fornix. So pain typically develops on the second or third postpartum day with a tender mass near the uterine conure, indicating ovarian vein involvement, especially the right ovarian vein. The diagnosis, how the diagnosis is made. So diagnosis basically relies on the clinical suspicion. If we do not suspect this condition, we would not be able to use the right modality of imaging, because here ultrasound is not going to help us much. It is the contrast enhanced CT that is the imaging modality of choice, rather than the MRI even, because that takes time. So the imaging modality of choice here is contrast enhanced CT scan, which visualizes the thrombosis and the surrounding edema as well. So this is a modern approach of diagnosing and managing this problem. So clinical suspicion, as I said, is the most important thing. If we do not suspect it, we just cannot reach near the diagnosis, and then we won't be able to treat it also. So clinical suspicion is paramount, then supported by advanced imaging techniques, including CT or MRI, to visualize thrombosis and surrounding tissue edema. Treatment protocol basically consists of antibiotics and the anticoagulation approach. So antibiotics, as Shobha Guri madam also said, that the escalation of the antibiotic protocol should always be there. So as soon as we receive the culture reports, we should be should be switching over to the antibiotics that suits her. Other than the antibiotics, it is the anticoagulation therapy, which is also of paramount importance. We start with the therapeutic dose of low molecular weight heparin, but then if the lady does not respond to that appropriately in next 48 hours, we may have to switch to the conventional intravenous heparin therapy. So these two are the main modalities of treatment. In very rare cases, if they both fail, we may have to use the venous filters, and very rarely a surgery may also be indicated. So these are the two figures before treatment and after treatment. As you can see, this is the right ovarian vein. So here it is showing thrombus in right ovarian vein. This thing, the same area now, the after the treatment, the thrombus has dissolved. So this is the patent right ovarian vein. So this is how it responds to the right kind of treatment. So how are we going to follow these ladies? Continued anticoagulation therapy is recommended for them for 3 months. We may switch them to oral anticoagulation therapy after a week. Then we need to rule out the thrombophilia after stopping anticoagulation therapy after 3 months. Then what about the future pregnancies? There is no need of thromboprophylaxis if thrombophilia has been ruled out already. And recent literature has also come up with the role of aspirin in when we do not find any cause, but there is a history of SPT in previous pregnancy, then we may start aspirin 150 mg right from the first trimester. So other than the obstetrics patient, like post-delivery, there maybe post-abortion cases also, which may present with SPT rarely. So the similar kind of vigilance is required in those cases also if a lady develops a high-grade fever after abortion procedures which are not responding to routine antibiotic therapy. In non-pregnant population, rare cases occur in non-pregnant individuals also, like in pelvic infection, that is PID, surgeries, uterine fibroids, or underlying cancer. I have seen a patient of SPT that was post-delivery, actually post-vaginal delivery. She presented with acute right lower abdominal pain. So she was suspected having acute appendicitis. She was open, abdomen was opened up, that was negative, and then there was a tender right-sided corneal mass. Then the abdomen was shut down. Then she was started with anticoagulation therapy and the broad spectrum antibiotics. So this year the DD was appendicitis actually. So only the suspicion of this problem can actually make you to treat it properly. So we have actually turned the tide. So this was the mortality rate. 50% historical mortality rate was there with septic pelvis thrombophlebitis. And now we have reached to 95% survival rate in modern times. So the mortality rates have drastically decreased from historical highs to much lower figures with modern medical approaches. That is early diagnosis and aggressive combined antibiotic and anticoagulant treatment. They are essential for a positive prognosis. So my takeaway would be that the vigilance is the key. So this entire ICOG infection program, if we talk about the SPT, it is a call for awareness actually. It is a rare but a very serious life-threatening condition requiring immediate attention. So the attention would only be given when we know the reason. So high index of suspicion is very important. Healthcare providers must maintain vigilance, especially with persistent postpartum fever unresponsive to initial treatment. Then yes, prompt action is equally important. So early diagnosis with right kind of imaging modality and aggressive management are critical to prevent severe complication and ensure patient recovery. So I have prepared this PPT with the help of Gamma AI app. Thank you so much for listening. Thank you so much.
Thank you, Dr. Binu, for an excellent talk. And you finished very much in time. And,
Please stop sharing, Binuji. Yeah, thank you.
And
Lovely.
you
Very
rightly
nice,
said.
crisp presentation. Yes.
Yes, ma'am. And usually you said that the right ovarian vein, it has a longer route, and the valves are also not very competent of the right ovarian vein. So the right-sided problem is much more there. And of course, the enigmatic fever, which you talked about, was very, very important because this fever does not respond to antibiotics. And there is a triad of injury and thrombosis and poor venous drainage. So this workhouse triad has to be looked after. So in all, it was a great talk.
It was very
Thank
good.
you.
Yeah.
Thank you.
Thank you so much,
Let
ma'am.
us very, very nice, crisp session that went. And let me thank Dr. Sheila Mane and Sadhna ji and Ashok Kumar and Pratik Tambe for giving us this opportunity. Binu, the one thing which I wanted to sign off on was that the preventive strategy is not only prevention of infection here, which we have been listening to, from the beginning, but also on the high risk factors which predispose to this condition. And all women who have had operative vaginal births or traumatic cesarean sections with a very stormy post-operative course, etc., we need to get alerted, as well as anemic women who have had bacterial vaginosis and were not treated for a long time or recurrent, diabetic women, obese women, hypertensive disorders where they have been at rest because of eclampsia, etc. All these women. And one category, of course, is HELLP syndrome, and especially if there is a renal failure added to it. So high-risk obstetric women are a danger for pelvic thrombophlebitis and pelvic thrombosis. And of course, we need to have a very high antenna of suspicion. So thank you, Binu. That was and it was very nice of you to acknowledge AI. because I think.
Thank you, ma'am. Because I didn't have much time, so I had to. Thank you.
We know. I think so. The prevention will be thromboprophylaxis, right? We should have that scoring system, no? Which
Yes,
our
ma'am.
COG
Yes.
follows. So what we have done is like we have pasted that chart in postnatal ward as well as in the postoperative ward.
Yes.
That scoring.
Yes.
So that according to that scoring, because
very nice.
everybody forgets. So we have laminated and put up those charts.
That's what I was trying to say.
Accordingly, thromboprophylaxis and hydration. See, Dr. Saroj mentioned about a discharge. It is very important if you are discharging early, because most of the time they don't hydrate them and give them enough water. So it is very important to hydrate them. Okay.
Yes, ma'am. Yes, ma'am.
Definitely.
We
If they
have
can
that is
oral,
excellent
not
presentation.
oral,
There
then
is
IV.
one question for
Thank
you
you,
to
ma'am.
answer. Please answer either in the chat box. Brilliant presentation, Dr. Saroj Singh and Dr. Vinu, and that makes the comprehensive, like both talk at the right time, at the right place, and by the right speaker. Vinu, there is one question. I think if you are not seeing.
He is left properly.
Vinu is there. There is one question, important topic actually. After how many days of fever, a pelvic thrombophlebitis should be investigated? So, you have said
No, it is not
about
how many days, ma'am. It is how much she has responded to the initial therapy. At least 48 hours we should wait after the starting of routine antibiotics therapy. And once we get the culture reports, we should be switching over to that therapy. But again, if she is not responding to the antibiotics to which she is sensitive, within 48 hours, we should be thinking about this septic pelvic phlebitis, or earlier if there are clear cut signs like tender pelvis, like right fornical tenderness. If there are clear cut signs, then we should be going for the right kind of imaging modality also. That is very important actually.
Thank you.
Yeah.
Great.
I
Thank
think
you.
imaging does have a very strong role in diagnosis, because then the therapeutic dosage of
Yes, ma'am.
antibiotics will
Heparin.
have to
Yes,
be.
ma'am.
Yes.
Gee.
Okay.
Since we're half an hour
Time
delayed
up.
already,
Thank you.
can we go to the next
Thank
section,
you, ma'am.
please?
Yes.
Thank you both the speakers and chairpersons for brilliant session. And now we can move to the next, that is fourth session, which is on maternal sepsis advances. And to chair the session, we have two brilliant chairpersons, Dr. Meenakshi Rohila ma'am and Dr. Monica Gupta madam. Dr. Meenakshi Rohila madam is a senior obstetrician and gynecologist, and she has received many prestigious awards, including FOGSI, Movicol Awards, first runner-up, and she has edited 2 books and contributed many chapters. I welcome you, ma'am. And can we have the senior madam? Dr. Monica Gupta madam is a professor at Safdarjung Hospital, New Delhi, and she is fellow from UK in urogynecology and pelvic reconstructive surgery, and she is chairperson of AOGD Urogynecology Committee and secretary AOGD FOGSI Delhi Society, and she is editor of many books.
Thank you, Dr. Kanchan. I think should move ahead.
Welcome you, ma'am, and I hand over the session to both the chairpersons.
Shall I introduce Dr. Shikha?
Yeah, sure. Dr. Meenakshi, go
ahead. It's my privilege to introduce Dr. Shikha Seth. She is a professor and head at AIIMS Gorakhpur. Hello, Dr. Shikha ma'am. And she has many awards to her credit, and she has been professor and head at other government institute as well at Noida and Etawah. And she has many fellowship awards and many paper publications award as well. So she has many extra mural projects also under ICMR and WHO. So I welcome you, Shikha ma'am. So please go ahead.
Thank you, ma'am. First of all, I would like to thank the whole of the ICOG team for giving me the opportunity. I think I am audible to everyone.
Yes, ma'am.
I want to share my presentation. Are my slides visible?
Yeah, please go ahead.
Okay. So The topic which has been given to me is conventional and newer markers of maternal sepsis, a really very important section for the postgraduate point of view. We know that what is maternal sepsis is whenever the infection is there and it leads to some dysregulated host response, the inflammatory response, and ultimately ends up in organ dysfunction during pregnancy or for 6 weeks of postpartum. This is called as maternal sepsis, and early diagnosis, delay in early diagnosis or treatment ultimately ends up in multi-organ dysfunction, the failures, and finally the death also sometimes happens. So this is a complete sequential aspect in which the infection takes place, it leads to inflammatory response, the SIRS, and then the organ dysfunction starts, ultimately the multiple organs, then tissue hypoxia, and finally the cell death takes place. So we usually define the things in these three sequential forms, that is the early signs of infection, then inflammatory signs, and then the organ dysfunction signs. So we have markers in the form of clinical markers, which we usually measure with the help of our general examination findings, and then we have laboratory markers to identify these things. So I will be discussing the whole thing in these two scenarios. The first, talking about the clinical markers. Clinical markers of infection are the early diagnostic markers, and once the stage is late, we come across some organ dysfunction, then also we have some clinical markers which define it, and they help in assessing the prognosis of the disease. So general clinical variables like fever, tachycardia, tachypnea, altered mental status, we all know that these defines towards that something infectious is there. And we have some clinical markers which help us in assessing those things, which includes QSOFA, as in the previous session also Madam suggested. It is a very simple thing, 3 clinical parameters, and anytime if the score comes out to be more than 2, it is suggestive that something infectious severe is there and the patient has to be admitted in an HDU or ICU setup. Iske alawa, we have MEOs, and the newer thing which has recently been considered is National Early Warning Score also, that is called as NEWS 2. It's a 7 clinical parameter score, more descriptive, and whenever the score comes out to be greater than 5, it is considered that is something serious is there, and we have to be very much alert and fast in treating this group of patients. So this news has got greatest sensitivity among all the clinical marker criterias like SOFA, MEOs, and something. This is recently has been come up also. Another clinical marker is a marker for the peripheral tissue perfusion is capillary refill time. It's a late thing. It is suggests towards the septic shock, and it guides us about the resuscitation, fluid resuscitation part. So early important thing, peripheral vascular perfusion, if it is falling, it means the vital organs are at stake. That's why the peripheral systems has been stoned down. So if we can find out these kind of a smaller clinical markers, it helps us in early diagnosing the severity of the disease also. Coming to the laboratory markers, again divided into infection, inflammation, and the markers related with the organ dysfunction. So multiple organs can be affected. The most vital organs are the brain, heart, lung, kidney. These are the things, and the liver. So the conventional ones are basically the CBC parameter, which we first of all do in all the infectious cases, like leukocytosis, the initial thing. Normally considered the cutoff is 12,000, but in pregnancy we sometimes consider it above 15,000. Late stages it enters into leukopenia. Neutrophil percentage increases. The left side shift of neutrophils. These are the basic common conventional clinical markers, inflammatory markers. Again, the CRP, that is C-reactive protein, which helps in complement binding to the dead cells. And whenever although it is very non-specific, but yes, whenever the condition, the marker value is above 2 standard deviation, it is highly suggestive of something very serious. Although it's not a good diagnostic marker, but it's very good marker of treatment resolution. Means once you had started treatment and the CRP has started falling, it falls early, and it helps in defining that our treatment is going in the right direction. Similarly, ESR, that is erythrocyte sediment tension, and again a very non-specific marker but highly sensitive acute phase reactant. And whenever the value is above 100, it's strongly suggestive of a basic baseline infectious processes there, although many limitations are there with this. In the late stages of disease, when the patient is coming to us late, it is associated with some organ dysfunction and later on enters into a tissue hypoperfusion also. So depending upon which system is affected first, we have different things, and we have a clinical laboratory criteria like complete SOFA, that is sequential organ dysfunctions in assessment, a scoring system which includes the basic 6 important organ systems. This is the general 0 to 4 scoring which has been given to this kind of a thing. And the another thing which is being commonly used in ICUs is the Apache score, that is acute physiology and chronic health evaluation system, which includes more number of physiological parameters, 12 physiological parameters they use along with age and comorbidities. So mostly the ICU people, the anesthetists, use this score, and this helps in defining the prognosis and the morbidity of the patient. So this is the complete score. Again, 0 to 4 score is given. So next, coming to the biomarkers. Biomarkers are those markers which are basically the lab test. Whenever they are abnormal in characteristics, they help in diagnosing and monitoring the things. So we test blood, we test urine, and we sometimes take the tissues also for the diagnostic point of view. And nowadays, the newer ones, which is the molecular and genetic markers. So the newer markers are procalcitonin, which usually rises within 4 to 6 hours of bacteremia. It is released from the thyroid gland, and the normal value is less than 0.1 nanogram. So anything which is more than 0.5 nanogram suggests infection. More than 2 strongly suggests that it is towards sepsis. And if it is more than 10, it is suggestive of a septic shock or a late stage of a disease. So although there is some limitation with PCT, that is, it does not clearly defines the viral infections or the chronic infections. For acute infection, it's a really good marker, sensitive marker, both under diagnostic and prognostic category. The second important marker is lactate, which is now added up into the diagnostic criteria of sepsis itself. So if lactate is there, it means the tissue is under stress. It defines the metabolic stress and tissue hypoxia. It gets raised in 4 to 6 hours of the infection process. An independent prognostic marker, cutoff value is considered as 2. And if it is more than 4, it means highly suggestive of septic shock or going towards a more morbid outcome. So this is again a very good treatment guide and the guide for the prognostication of the disease or the severity of the disease. New hematological biomarkers are also recently been added up. These includes the NLR, that is neutrophil to lymphocyte ratio, if it is more than 5. Platelet to lymphocyte ratio, if it is more than 377, cutoff given by some of the good evidence research article. And immature granulocyte count or immature to total granulocyte count. If immature count is more than 10%, it is again suggestive of something very problematic is there. And the recently added one is the monocyte distribution width. So all these things can be identified with the help of a complete detailed CBC report. Although these are all non-specific kind of a thing, but they are very good in those group of patients who presents with the non-classical presentation. So like just previous session we talked about that subpelvic thrombophlebitis or something like that, some where we don't have a direct kind of a presentation. These kind of hematological biomarkers can be helpful in defining that something septic foci is there inside, which we are not able to. A new potential biomarkers which has come up and under being researched recently are neutrophil CD64, presepsin, interleukin 6, STREM1, and more. So I will be talking about few of them which are majorly researched or they have been utilized. One is presepsin, which is actually a soluble CD14 content. that is secreted by the macrophages, and it actually binds to the bacterial liposaccharides. And what it does, it when it binds, it activates the innate immune system. It is a very initial kind of a marker because it rises within 2 hours of the bacterial infection. So it has diagnostic as well as prognostic indications. There are two types of CD14 things, but the soluble one is available in the blood, so helps us in identifying this thing. Another marker is interleukin 6, a glycoprotein which is secreted by the macrophages, and it activates the B and T lymphocytes, again rises in 2 to 3 hours time. So very good thing. Newer biomarkers include CD64, TNF alpha also, although they are not routinely in use, but they have got a good sensitivity and specificity. Another new marker which has recently added up in the panel is methylglyoxin, which it's an experimental marker, and it is based on the concept that whenever the sepsis is there, it leads to the dysregulation of the glycolysis pathway also, because finally the acidosis develops. So metabolic and the inflammatory pathway के combination के derangement को ये दिखाता है, and it is basically, it has got a good diagnostic and prognostic criteria also. So this is a recent study, which clearly defines that the comparison of the conventional marker, that is C-reactive protein, the thing of procalcitonin, and the latest marker, that is presepsin. So we can see that the graph of the presepsin is most towards the left, has the maximum area under curve, and it has excellent diagnostic and prognostic prevalence. Among the newer things, once we have got the whole blood genomic expression, we have come across many robust diagnostic options with us in the form of molecular biomarkers or molecular tests, which include cell-free DNA, proteomics, metabolomics, and transcriptomics. A biosept study is there which defines all these varieties, because we know what inflammation happens. This is a slide which comprehensively describes the various under-researched biomarkers related with the sepsis. And the metabolomics are the one which is associated with the metabolization of proteins, glucose, amino acids. The proteomics ones are which is related with the endothelial injury, because endothelial injury is responsible for the complications in the whole of the body. Similarly, some of the changes are associated with miRNA related things, and the transcriptomics are basically associated with the how this inflammation relates to the formation of some of the substances like interferons and all these things. So there are n number of panels. There is no single definite marker which helps in diagnosing, but it is a group of the I must say a panel of biomarkers which need to be done to identify the particular in sepsis foci is there or not. So this group of biomarkers, it's beneficial in two senses. One is they are early in detection, because before the clinical appearance happens, this develops, this can be identified. Secondly, it gives us help in individualized or personalized treatment or precision medicine point of view. So the final take-home message is there is no single biomarker which is sufficient, be it a conventional one or the newer one. We need a panel of the things. We should combine clinical as well as biomarkers, inclusive of the molecular panel also, which helps in increasing the efficacy of our diagnosis and the treatment aspect. The diagnostic markers, conventional markers will never be out of date, because they will help in monitoring the disease, defining the treatment outcome, whether it is working well or not. And the newer prognostic markers, clinical as well as laboratory ones, will help in not only in early diagnosis, but defining in future maybe the therapeutic options also. Recently, the international guidelines on the management of the sepsis and septic shock for 2026 has been also released, which also defines some of these kind of things. So thank you very much for giving me the opportunity on this particular session. Thank you.
Thank you, Dr. Shikha. It was, I think, a wonderful presentation and a beautiful compilation of all the biomarkers But I really like the last concluding slide of yours, it was the take-home message, because it's very important to understand that these biomarkers, by and large, are not actually the diagnostic ones, but most of them are used to prognosticate a patient who would eventually require, something like a HD or an ICU care, and how well and how aggressively we should be managing a particular patient of sepsis, and can predict outcomes on the basis of already done studies. But unfortunately, most of the newer ones, the molecular ones, and the much talked about recent biomarkers are under all experimental stages and research stages. So by and large, through this certificate course, I'm sure all should get this message that yes, a lot of work is being done world over for better prognostication of such patients, but we should not miss out on simple clinical things, something very basic like q-sofa, capillary refill test, as you very rightly said. The early, that golden hour in which we can just see, think, and make all our team aware that yes, we are here to deal with the patient of sepsis, will be the key to manage them successfully. A wonderful talk, Dr. Shekhar.
Excellent talk, Dr. Shikha. Excellent. Hi, Monica.
Good afternoon, ma'am.
Congratulations. Yeah, very excellent talk. I think
yes.
nice compilation of topics by Dr. Sadhna Gupta. Very nice.
I think we have a very good appreciating message and a lot of discussion on chat box also. So
And even now there are nearly 500 people attending.
Yes. So Kanchan, we are 30 minutes late, and Pratik is there with his background to remind us that we are late. So we can make a brief CV and start the next session immediately. Thank you, everyone.
Okay, ma'am. Yes, ma'am. Go ahead, please.
So it is my proud privilege to invite the next speaker, who's none other than Professor Dr. Sarita Agrawal, who is the professor and head of obstetrics and gynae department from AIIMS Raipur. And she's got various accolades to her credit, and she has a wide experience of 24 years of teaching experience, and is basically interested in laparoscopy and robotic surgery. So over to you, ma'am, and we are very eagerly waiting to hear your talk.
So thank you very much, Dr. Monica, for introducing me. And I will definitely like to thank Dr. Sadhna Gupta for involving me in this certificate course. And I think if my screen is visible.
Yes, ma'am. You'll need to share the PowerPoint window.
Yeah, I'm just
Currently sharing your browser.
Is it okay now?
Not yet. We'll have to stop sharing and share again. We can see your ChatGPT windows.
But this is the stop sharing I did. Share screen. Then I should share the entire screen, no?
No, you need to share the PowerPoint window. Open the presentation and share PowerPoint.
Not showing. My whole screen is visible. How to make it PowerPoint? Is it visible now?
Yeah. Please go full screen.
Fine?
Yeah, perfect.
Okay, thank you. So thank you, Dr. Sandy, for helping me in sharing the PowerPoint presentation. I know the 15 minutes time I was thinking is going to be less for me to talk on the sepsis care bundle revised guidelines, but the previous speaker has definitely made my life easier. So I am going to cover the recent guidelines based upon the Surviving Sepsis Campaign Bundle 2018 update, 2023 update, and the latest 2026 April 26 updates on Surviving Sepsis Campaign. So when I'm going to talk based upon this, the definition sepsis is being given life-threatening organ dysfunction due to dysregulated host response to the infection, and when the maternal, it is related to pregnancy, childbirth, post-abortion, and postpartum. So over a period of time, different definitions have been given, but the most accepted definition is the sepsis 3, which defines the sepsis as life-threatening organ dysfunction caused by dysregulated host response to the infection. An organ dysfunction is said when the sequential SOFA score is more than 2. And the septic shock is very important, one has to recognize. So that is a subset of sepsis associated with circulatory and metabolic cellular dysfunction. It exists when the vasopressors are required to maintain a mean arterial pressure of 65 mm or greater. And when the serum lactate, a very important biomarker, when it is greater than 2 millimoles per liter, following adequate volume resuscitation. So it matters because it is a major cause of maternal mortality, time critical condition where the early recognition, early treatment is life saving, and antibiotics within 1 hour is the key determinant. Even a delay of hour can kill the mothers, and highly preventable disease. So we know the different causes discussed by the previous speakers. When to suspect also has been discussed by Dr. Shikha. But here I want to highlight that tachycardia and leukocytosis are two things which can be common in the pregnancy, and that may let us to delay the diagnosis of sepsis in pregnancy and obstetrics. So we have to be very careful when you're diagnosing the sepsis. So the red flag signs, various scores, various pregnancy-specific scores come into play, but none of them are ideal screening tools. And the news and the muse score are being recommended for doing the scoring rather than the Q-SOFA as a screening tool as per the new guidelines. So the Surviving Sepsis campaign, the 2026 says sepsis is a clinical diagnosis and should not be ruled in or should not be ruled out using a single biomarker or a diagnostic test. So the clinical criteria is very important and making a suspicion a red flag for the sepsis. The sepsis care bundle, by definition, it means a group of evidence-based interventions performed together within a specific time frame, that is within 1 hour, and to ensure early recognition and rapid treatment, that is, do the right thing fast and together. So why this is dated? There's an evaluation. This is the year-wise chronological evaluation coming from the campaign 20. Surviving Sepsis campaign 2002 to 16, the WHO initiative, then FAST-M, and then AIM, and then the current. So the current is a most accepted approach is 24-25 is an integrated approach which is globally accepted, and the combination model is recommended where the core clinical bundle is FAST-1 WHO standard, where the FAST F means for fluid, antibiotics, source control, transfer to ICU, and monitoring. The time critical care involves the 1 hour sepsis bundle, and I'm going to take this detail, the 1 hour sepsis bundle, and the system framework in order to improve the quality and the implementation model where the treatment bundle is shifted to the health system bundle, which includes readiness, recognition, response, reporting, and the respective care. So this is how the 1 hour bundle has been evolved. The 3 hour initial 6 hour bundle and 3 hour bundles have been combined to make a 1 hour bundle, because the 1 hour bundle has definitely shown on various trials to have a very effective control and decrease in maternal mortality. So the golden 1 hour includes the 5 things: for the measure lactate level, obtain blood culture before administering antibiotics, administer broad spectrum antibiotics, the fourth begins the rapid fluid resuscitation, and the next task is to apply vasopressor to patient with hypotensive even after fluid resuscitation. So we're taking one by one. Measure lactate level. That means you have to measure the initial lactate level at admission, that is the 0 hours. If the level is more than 2 millimoles, start fluid resuscitation and measure every 2 hours, which is going to guide further what fluid resuscitation, how much fluid resuscitation has to be done. And target is to decrease 20% by every 2 hours. There are other measures also being included, that is an mean arterial pressure to be more than 65 millimeter and a CO2 of more than 70% when the central line is in. Because this lactate level actually talks about the balance between oxygen delivery and oxygen consumption reflected as a tissue perfusion. How the lactate does this? Whenever there is a tissue hypoperfusion, there is release of the lactate, and that actually guides you how much is the tissue destruction is ongoing. So this is most important part on the shock, septic shock. So you have to monitor with the lactate level. The second is obtain blood culture before administering antibiotics. This is very vital. Even the first dose of antibiotic can let your blood culture to be sterile and may not be able to guide what antibiotic subsequently. So the 4 sets of blood has to be collected, 1 from the center, 2 from the central, 2 from the periphery, and both aerobic and anaerobic culture has to be sent. Apart from the blood culture, the vaginal, uterine, respiratory, urine, and surgical site infection site has to be collected based upon what is the site of infection you are perceiving, seeing which is the cause for the sepsis. The third part is administrating broad spectrum antibiotics. I'm going to elaborate a little bit more on the broad spectrum antibiotic here. So antibiotic time is very crucial, should be initiated within first hour of the recognition that sepsis is there. And the empirically means you have to start on a wide spectrum activity covering both positive, negative, anaerobic, anaerobic. And it is usually recommended when the patient is already in sepsis, recognized in sepsis shock, the higher antibiotic in the form of carbapenems and anti-gram-negative microbial has to be done. The dual coverage here is mentioned, which mentioned when the gram-negative organism is suspected, when you are suspecting multi-drug resistance. On that, it is always preferable to use the gram-negative dual coverage in that. About the dosing, it is very important giving the loading dose. You have to give the loading dose to attain the peak MIC as early as possible, because this is the time when the microbiomes are going to be cleared with the antibiotic, and the further dosing has to be managed, the timing and the frequency as per the T-half of that particular antibiotic. So the level of the antibiotic in the circulation should be more than MIC throughout the treatment time. And of course, because in sepsis there may be renal and the liver function disturbances has to be calculated as per the renal and the liver dysfunction profile. Now, once the antibiotic is started, about the de-escalation, when to stop or when to change the antibiotics. So, if you get the culture report then and you find that what antibiotic is started is not sensitive, on that case, the antibiotic needs to be changed as per your culture profile. And then how long the antibiotic has to be continued? There are the short duration courses and the long duration courses. However, the multiple trials have shown whether short and long does not have any long-term benefits. So therefore, the new guidelines recommend the short treatment courses. Then what long in the short treatment courses, the guiding, as Madam was talking about the procalcitonin. The procalcitonin is widely used for differentiating bacterial from the non-bacterial infection, because this spores may be high, absence of fever may be there, but other criteria may be fitting into the patient to put in the sepsis. So if you are suspecting that it can be non-infectious, then the procalcitonin may be helped. Then second, the procalcitonin is important is that it may help to decide the duration of antibiotics. That means if you are getting the procalcitonin level to be less than 2, you can stop the antibiotic safely. But it doesn't mean when you have a sepsis clinical features to consider procalcitonin when to start antibiotics. So this is very important about this. Then the risk for bacterial resistance is all. This list is given in 2023 update about the MRCA, ESBL, Pseudomonas, Candida. If you suspect that these risk factors are there, and you have to choose the antibiotic based upon this profile. So the most common antibiotic in the gynecology is for the urinary and the obstetric infection, where the first choice, second choice based upon the risk factor. This list is also available. The usual starting is the piperazine tazobactam or the clindamycin, gentamicin as the first line, or the second choice in urinary is ciprofloxacin. But if it is a nosocomial infection, you should choose the meropenem. And gynec infection, again the clindamycin and gentamicin is good enough. But if the risk factor of ESBL or MRSA is there, then the meropenem is the drug of the choice. So there is something new has come in the 2026 guideline. They have classified the sepsis into the definite sepsis, when alternative diagnosis is very unlikely, probable sepsis and the alternative diagnosis is less likely, and the possible sepsis and alternative diagnosis is also likely. So when to start antibiotic for that, they say sepsis is definite on probable. Whenever the definite sepsis is definite, probable, or possible, and shock is present, start antibiotic immediately. That is within 1 hour the recognition. But in case the shock is absent and definite and probable, then again you have to start within 1 hour. Only in the condition when sepsis is possible and shock is not there, then you have to investigate it. Once the source of infection pathology is proven, then it has to be started. Then again the delay should not be more than 3 hours. That is very important. Otherwise, you will have a poor prognostic outcome. So possible diagnosis without shock, rapid assessment is to be performed, and once the sepsis is confirmed, start within 3 hours. In all other cases, it should be started within 1 hour. The fourth is begin rapid administration of crystalloid for hypotension and when the lactate level is more than 4 millimoles per liter. So what amount of fluid has to be transfused? It is debated, but Certain sepsis campaign indicates more than 30 ml per kg IV crystalloid should be administered within first 3 hours. And then current changes to individualized fluid therapy. Then how to individualize fluid therapy? So in that case, you have to monitor the fluid tolerance and the fluid responsiveness. So they say once you have to give a bolus dose of 250 to 200 to 500 ml in first to 10 to 15 minutes and see increase in stroke volume. If it is more than 10%, that is a fluid responsive shock, and then you have to continue with the fluid resuscitation. So other dynamic tests are being more stressed upon to look for the fluid responsiveness, and they are the passive leg raising test, the IVC collapsibility, and the capillary refilling time, which are used to be in something like capillary refilling time is not being used for years together, but it is still being recommended that in 2026 that a passive leg raising capillary refilling are the good thing in the resource poor setting where you can diagnose whether the patient is a fluid responsive or not. It is very important when you are giving the fluid therapy, then the fluid overload is another risk. So, and that can lead to worse outcomes. So you have to look for the fluid overload by auscultating just looking the edema and all. So the recommended nowadays, the practical approach is give a small repeated bolus, which will avoid the fluid overload, then continuous monitoring and early vasopressin adding definitely reduces the requirement of the fluid, and that can reduce the risk of the fluid overload. And there is a new protocol which is being given the restrictive fluid giving. That is a restrictive versus a liberal fluid category, but there is no change in all of these two. But this is the individualization based case to case that we are going to go for the restrictive versus the liberal category for the fluid management. So use of dynamic variable rather than the static CVP measurement is important. So they revive the clinical skill of the passive leg raising. IV this capillary refilling, it is very good if you have an ultrasound because yourself can measure the IVC collapsibility index, and that is a very good marker to tell whom to be given the fluid. Then next, which fluid to be given? The normal, saline, or the balanced? That is a lactated ring of the plasma light. So balanced crystalloid is the fluid of choice, composition close to the plasma. Chloride-rich solution, of course, is widely used, but there is a high risk of hyperchloremic acidosis, specifically when the high fluid is used. Then about the colloid, no guidelines recommend using the colloid because increases the risk of tubular necrosis and acute kidney injury. The one thing is about albumin. The role of albumin is debated because in sepsis usually you find the albumin is low, and that is the giving the albumin can improve the oncotic pressure that can help improving the shock, but the long-term mortality benefit is not being answered with the albumin therapy. However, if the women is requiring large dose of the volume crystalloid, and that with albumin may be one of the advisable thing, but has to be given with the very cautiously. So this is the repeated small bolus with continuous hemodynamic monitoring is a new concept recommended in 2026, which we can go for this. Then the next pillar is vasoactive agent. The drug of the first line of vasoactive agent is a norepinephrine. Starting dose is 0.1 to 1.2 microgram per kg per minute. It's very important and it is very useful as vasoplasia is there in case of septic shock, and that by vasoconstriction it helps in vascular filtration, redistribute the blood flow, vasoconstrictive effect improve the myocardial contractility, and the targeted MIP when you're using the vasopressor or the fluid resistance MAP of more than 65 millimeter. Then adding vasopressin once the norepinephrine is not able to achieve the target MAP is a good choice. The dose is 0.25 to 0.5 microgram per kg per minute. So adding vasopressin actually avoids the adenosine overload. That norepinephrine has its own side effects in the form of tachycardia. So this can be avoided if you add the vasopressin. So balancing between norepinephrine.
Sorry to interrupt you, ma'am. Your time is up, ma'am.
I'm just taking another 2 minutes. Then epinephrine has to be added. About the inotropic agent, if there's associated cardiac dysfunction, dovitamin can be added. Hydrocortisone role is again very controversial, but the recent guidelines show the glucose and the flucortisone improve the outcome. Oxygenation and ventilation, that choice, of course, oxygenation starts at 50 liters per minute of reservoir mark. So given a choice, HNFC is much better as compared to the mechanical ventilation. With mechanical ventilation, you have to use a low tidal volume ventilation where the 6 mm per kg is the target. Additional treatment, heparin, glycemic control, proton pump inhibitor, renal replacement therapy, sodium bicarbonate, source control, gut products, nutrition, everything is very well defined in this. Admission for ICU criteria is also well defined. And then the management supply, antimicrobials within 1 hour, fluid as fast as possible, guided by FT and FR. Vasopressors, early start is recommended to attain the mean archer patient of more than 65. Oxygenation target SpO2 of 94 to 98%. And HNFC is preferred and LTVV 6 ml per kg. Others has to be always given into consideration for the better outcome. This is the flowchart given in the Surviving Sepsis 2026, which every PG can go and see that. So thank you very much. Recognize, resuscitate, and refer.
Thank you, Sarita ma'am, for excellent talk. And I request your persons to give a quick remark so that we can move to the next session. We are running short of time.
Thank you, Dr. Sarita, for thank you, Dr. Sarita, for a detailed yet a very clear talk. I just would like to add a statement that to diagnose a sepsis, we have to have a very high index of suspicion.
Yes.
And whenever we have a suspicion, we need to hit early and hit hard. So what do we mean by this? That whenever we have a suspicion for antibiotic dose, we have to hit early within 1 hour whenever we are sure with the score. And we have to be with the full doses of the antibiotic. Many times the renal function is not correct and the creatinine may not be in the normal range, but still we have to give a first dose has to be a good hard amount and a very good actual dose of the antibiotic that has to be given. So with these words, I would like to thank the whole ICOG team and Dr. Sheila Mani ma'am, Dr. Sadhna and Dr. Ashok. So thank you very much for involving me into this very prestigious program. Thank you very much.
Thank you. Thank you, Sikha ma'am, Sarita ma'am, Monica ma'am, and Meenakshi ma'am for the excellent session. And
Thank you for the ICOG team for having us here, and wonderful talk, Dr. Sarita, especially the compilation of the recent Surviving Sepsis campaign 2026 guidelines, which is a must know for every practicing clinician.
I think every PG should reach this thing and they will have a very clear concept how to go ahead, and very well defined. No confusions at all on that.
Thanks for that. Thanks for that, ma'am.
Thank you, ma'am. And now can we move to the panel session? And can we have CV of our moderator, Achla Batra ma'am and Vidushi Kulsrestha ma'am? We all know Achla Batra ma'am. Ma'am is a currently governing council member ICOG. And
Kanchan, time is very less.
Yes, ma'am. And Dr. Vidushi and Dr. Vidushi. So, ma'am, I hand over the session to you to introduce the expert and panelist.
Okay, then I have with me two experts, Dr. Balad, who is a Professor, Unit Head, Department of Obs Gynae, Kehar Jawaharlal Nehru Medical College, and has had many leadership positions in Karnataka.
Madam, just enough. That is.
Yeah. And I also have with me Dr. Rekha Bharti, who is a professor at Septic Hospital and has worked very much in HDU and very well versed with the HDU settings. And I have my panelists. They're all HODs, Indrani is HOD of Nazrat Hospital, Shillong. Then I have Shikha, who is a professor, head of the department of SN Medical College, Agra. And I have Suchi, who's an associate professor and has been winner of many prizes. Then I have Sangeeta Arya, who's also a professor, head of department of Kanpur, DBSKMS, and of course, Dr. Alok, we all know, who's very active academically, is assistant professor at Himachal Pradesh. So I would like to share my screen now, and I think, can I share my screen now?
Yes, ma'am.
But okay, fine. So I think most of the previous talk has really made like nothing is left, but we'll go according to the case. I will not talk about any overview, but one thing I want to say that most cases of maternal death from sepsis are likely to have been preventable. And in India, we can see it is the third important cause of maternal mortality. And causes can be, of course, obstetric, non-obstetric, both can cause sepsis. And sepsis results in organ damage. All the organs are affected. So we'll straight away go to the case. Mrs. S, P2L2, underwent
Ma'am,
the
you need to share your screen, please.
Presentation आपका share नहीं
You're not, I'm not sharing my screen?
No, ma'am, it's not yet shared.
Okay.
विदुषी आप अपने से करोगे क्या?
Let try, ma'am.
हाँ, you must have be share ना, so you try from your end. Yes.
अच्छा, वो स्टॉप शेयर नहीं किया था अभी तक।
ये आपने किया है, मैंने किया है।
अच्छा, चलो आप कर लो शेयर फिर। आप कर लो विदुषी।
हो गया क्या शेयर?
हाँ, yes.
Just go full screen, ma'am.
Yeah.
हाँ, विदुषी full screen चलेगा।
Yeah, good.
So come to this, Vidushi, come to the case straight now.
Yeah, ma'am.
Because all the definition, everything has been covered.
Yeah, everything is covered now. So shall I start, ma'am?
Yeah.
So this lady was para to life 2, has undergone cesarean for second stage for arrest of descent, and it was all uneventful. So she was in the wards, and on the third post-operative day during morning rounds, she complained of pain in abdomen and vomiting for last 4 hours. So on a quick assessment, she appeared drowsy, responding to verbal commands. Her GCS was 14, and she had warm peripheries. So her vitals were quickly taken, and which showed tachycardia with a pulse rate of 130 per minute. It was feeble. She had tachypnea with respiratory rate of 28 per minute. Her BP was 76 by 48, making a mean arterial pressure of 57 millimeters of mercury. And on room air, her SpO2 was 92%. Though her respiratory and CBS were within normal limits, and on per abdominal examination, her abdomen was found diffusely tender, and the bowel sounds were sluggish. So while a patient was being evaluated, her dressing was dry, but it was opened up to examine the stitch line, and a purplish discoloration was apparent, which was extending over, especially over the ends. PV revealed scanty discharge and appeared purulent. That scanty discharge was apparently purulent. So, Dr. Indrani Roy, what is the diagnosis of this patient?
Yeah, thank you, Sadhana ma'am, and the entire team ICOG for giving me this opportunity today. So, if you see this case, initially her presentation, the first thing, she's complaining of pain. So we know that pain, it is a very important symptom. Why I'm telling? Because normal pain, any postpartum pain, usually within 24 to 48 hours, it should subside with normal analgesics. If the pain doesn't subside, persistent pain, even with analgesics, that should arise one suspicion. Then she's having systemic symptoms. She's having tachycardia, hypotension, her respiratory rate is more than 22, SpO2 is less. So, and plus the local examination of the wound, that is also showing discoloration above and purulent discharge. So first diagnosis in my mind will be definitely sepsis. And the most important thing in diagnosing is that we tend to miss. We have to think sepsis, then only, that has been told in all the previous lectures, that if you think sepsis, then only you will be able to diagnose. So first thing, it will be a wound sepsis, that there is wound induration. So she is a case of sepsis, and I will suspect wound necrotizing fasciitis here. And whether she's in shock or not, we'll have to do some more investigation to find out how severity is the sepsis.
Absolutely correct. So we move on to the investigations. So Dr. Shikha, what are the investigations that you would like to have?
Good evening, everyone.
a very nice session, and thanks to the coordinators, Sadhna Gupta ma'am and Ashla ma'am, for having me in this session. And a question what the investigations we should do, uh, complete blood count, and also the liver function and the kidney function, along with the cultures should be sent, the wound that is seemingly infected, the swab culture sensitivity from the wound site, urine culture, blood culture, and also the biomarkers for the sepsis, which is becoming the diagnosis almost sure by the clinical examination. So the biomarkers for early detection, lactate levels for detection, procalcitonin, CRP levels, and other markers which are not in the first line, but if possible, we can also send the other markers. So all these investigations, plus we should be investigating for the site of infection. Like there is a purulent discharge per vagina. So the ultrasound scan of the abdomen for any collection in the pelvis or in the uterus, that should be a part of the diagnostic investigation for the source of infection. Baseline. After that, we can have the other.
You have comprehended all the investigations that should be sent. However, I would like to add here that first hand we should also send a sample for ABG so that we know.
Yeah.
So, Dr. Alok Sharma, would you like to it is all covered, so like SOFA score, but what is the importance that you can tell? So it was the earliest
previous speakers have already discussed that SOFA score, but I think with SOFA score it is like so many used, most of the time it is used in ICUs and in a septic shock patients. So why not to use like quick SOFA sort of thing? Like assess this, quick SOFA is the good thing to assess. So we can go for SST for the assess the severity of the organ dysfunction and its sepsis. Predict the mortality.
As is shown here, that SOFA requires investigations also. As Dr. rightly pointed it out, that clinically it will be more pertinent to use quick SOFA or obstetrically modified Q SOFA score. So, Dr. Indrani, would you like to throw some light on this? Dr. Indrani, please.
Yeah.
Difference between Q SOFA and
so quick SOFA is like, because SOFA we need all of lab investigation, so it's mostly a retrospective diagnosis. So in quick SOFA we should see the general condition, the altered, whether she has having altered mental status, then we see the respiratory rate if it is more than 22, and then the systolic blood pressure. So it should be less than 100 systolic blood pressure, then that is considered as out of these three parameters, if two are positive, then she is considered as in a high risk category. So these three factors are taken into account.
What is the importance of obstetric modification?
So in this is according to the changes of the physiological changes which occur. So we use the quick SOFA, and here the respiratory rate is taken a little bit higher, that is 25. And the SBP, that is the systolic, which is 100 in quick SOFA, this is coming to 90. The baseline, that takes into 90. If it is less than or equal to 90, then that is taken into consideration.
Yeah, so nicely
and the
said.
GCS, obviously, if it is less.
Physiological changes, so obstetric modification is better than Q SOFA for assessing our population. So, as you rightly said, score of 2 or more needs shifting the patient to ICG or intensive monitoring. And however, when possible, now you can send the investigations that Dr. Shikha told, all the investigations. So later on, you can apply a full SOFA, as Dr. Alok rightly said, it is done in the ICU settings. So now that concept is also coming of two-step screening tools for obstetric sepsis, where the first step is to identify warning signs using either of the basic tools. And the second step, of course, is to test for end organ injury, because that is mandatory to establish a diagnosis of sepsis. Right. So continuing with this case, her CBC showed a raised TLC of 28,000. PTNR was 1.3. KFTs were deranged with creatinine of 1.8. LFT bilirubin was raised to 1.2, and OTPTs were also higher. And ABG revealed a pH of 7.27. PO2 was 67. PCO2 was 16. bicarbs were 12, lactates were 4.5, and there was an iron gap of 22. And by this time, ultrasound was also done, when we showed a postpartum uterus with minimal collection in the pelvis. So what, as it has been told in all the previous presentations, but still we will recapitulate that what are the components of 1 hour bundle for immediate management. Dr.
Hello.
Shuchi,
Yeah. So good evening, everyone. Yeah, there was some confusion. I think I was wrongly added to the group. I am Dr. Shuchi Jain. I am Professor HOD at MJIMS Sevagram. So the immediate components of 1 hour bundle, as elaborately explained by Sarita Madam, it is the Surviving Sepsis Campaign 1 hour bundle, which is a set of critical evidence-based interventions designed to be initiated within 1 hour of sepsis in recognition to reducing maternal mortality to sepsis. It includes measures like measure the lactate level and remeasure if the initial lactate is more than 2 millimoles per liter. And obtaining blood cultures, take samples prior to administering broad spectrum antibiotics. Administer broad spectrum antibiotics, often in combination with cultures, and begin administrating 30 ml per kg crystalloid for hypertension or lactate for more than, if the lactate is more than 4 millimoles per ml.
Those details later on, just recapitulating.
Yeah, and apply vasopressors. So this comprises the 5 steps of the bundle for 1 hour, like 1 hour sepsis bundle.
So things remain the same, but various authors have come out with various mnemonics, various things. So another thing is the sepsis 6, which is to be initiated within 1 hour. So again, the same things. There they have added the oxygenation part and urine output monitoring, which we are all doing. And then fast M, as was discussed in previous presentations. So basic important thing is also to find to have the source control and transport to higher levels, or even if the patient remains with you, then transfer to a higher level of care. So it's not that you have to transport, you may have to shift her to HDU or from HDU to ICU. So you may have to escalate the level of care also, and of course ongoing monitoring. So it has been seen that completion of sepsis 6 within 1 hour reduces mortality significantly. For every hour of the delay in antibiotic administration, there is 8% increase in mortality. And sepsis can rapidly progress to septic shock with mortality rate of 50%. So it is very important to act timely. So Dr. Sangeeta, how much fluid you will give, though it has been covered, but just again a quick recapitulation.
Ma'am, by the large bore IV cannula, whenever we are dealing with the OBS patient, we should always put a large bore IV cannula. We have to give 30 ml per kg of crystalloids, RL or NS is to be taken for first 3 hours. In the initial phases, we can give 250.
Sangeeta, I would like to interrupt that we prefer crystalloid and don't give NS in septic shock.
Yeah, I think crystalloids we prefer. And initial boluses of 250 to 500 ml can be given over 15 to 30 minutes. If the signs and symptoms of the patient suggest, then we can go up to 1 liter of the fluid up to 30 minutes. And then after this after giving this fluid, we have to reassess the vitals of the patient. We have to reassess the mean arterial pressure of the patient. It should be more than 65. And decreasing pulse should settle with the increasing given amount of fluid. Her mental status should improve, and the capillary refill time should be less than 2 seconds. That means that warm peripheries have occurred. Urine output should be measured. It should be 30 ml per hour or the 0.5 ml per kg per hour urine output should be there. And obviously the decreasing lactate levels should be there. And in any case, the mean arterial pressure is not increasing, then we have to go for the vasopressors. As already been told, we can first give her norepinephrine in the doses of 0.1 to 0.5 microgram per kg per minute. And anyhow, we are suspecting myocardial dysfunction, we can go for the dopamine infusion also. And if we have got the patient is in ICU setup, then we can measure the central venous pressure. That should be within 8 to 12 millimeters of mercury. And if we have got the ultrasound facility, then we can go for the IVC distensibility index also.
to assess the adequacy of the fluid what we have given to the patient. If patient is spontaneously breathing, then at least 50% with a sniff, there should be a more than 50% distensibility of the IVC should be there. And if we have taken the patient on the mechanical ventilation, it should be more than around 18%. The distensibility index is there, then the patient is giving the fluid response properly.
So the backbone of sepsis management is antibiotics. So, and if you don't give antibiotic properly, it can affect the management, and we will not be able to. Just a minute, my battery is going.
Hello. Hello.
Hello. I think ma'am is connecting her laptop to the charger. So in the meantime, I may ask Dr. Shikha, what are the preferred antibiotics for obstetric sepsis?
Yeah, when the obstetric sepsis, we have to control. We have already sent the investigations for the cultures, the wound site, the urine, the blood, but the results will be available in 48 to 72 hours. And we have to start within 1 hour of diagnosis of sepsis, the antibiotics, which should cover the anaerobic, aerobic, and should be wide spectrum antibiotics. Within 1 hour, they should be started. And the de-escalation is also necessary, but that will be done according to the type of culture report, which will be available in 48 to 72 hours. Within these 48 to 72 hours, we have to give a wide spectrum covering all the aerobic, anaerobic also, and the most common one being used the clindamycin or metronidazole, and along with that MP or Genta, or we could use meropenem and tazobactam. And if MRSA is suspected, we should also start the linezolid or vancomycin. And these all should continue for the first 72 hours. Then after the culture report, we can modify and de-escalate. But initial coverage should be with all these antibiotics.
Yeah, and the latest 2026 guideline also say that giving it for a beta lactam for a prolonged period instead of just giving 6 hourly, 4 hourly. It's better to give a bolus and then continue the infusion over a long period. That is more effective than just giving every 6 hours or whatever is the required dose.
Yeah.
And suppose the focus is not clear, then what antibiotic should be given?
Madam, I think if Madam has said, if we have sent all the cultures, now we are waiting for the cultures. So till then, ampicillin, metronidazole, and gentamicin, this trio is very good and a broad spectrum, which
No,
can be
Dr. Alok, it depends on what you are dealing with. That's what
dealing with.
it's about. If you are dealing with necrotizing and fasciitis, you have to start with higher antibiotics.
Yes,
Otherwise, you will not be able to control it. That's why the Vidushi, can you go back?
Yeah, and one more thing, in this case, the lactates are more than 4. So it is that we should be guided by what the lactate level. So we should start with a higher antibiotic here.
Next, yeah. Next. See, there are guidelines for everything. Like if you have no shock, then Ampi, Genta, Metro are good enough, like you said.
Yes, ma'am.
But if you have shock, then you have to have higher
Yes,
antibiotics.
ma'am.
If you have a condition like necrotizing fasciitis, then you have
Then
to
we
have
have to go.
higher antibiotics. Yeah, Vidushi. So when if the focus is unclear, then you have to give higher antibiotics because you don't know what you are dealing with.
Yes.
And you have a patient of severe sepsis, you are not able to find a focus, then at least 2 antibiotics of different antibiotic classes should be given if they have shock. And of course, if you have risk factor candida, you can add for that. Otherwise, antifungals are not recommended. And procalcitonin, which has been done earlier, that can assist us in, guiding us how the antibiotic has to be proceeded, whether to increase or decrease. Next. Now, Dr. Alok, we have given fluid, we have given antibiotic, but patient needs more therapy. What is this supportive therapy which the patient needs? Because her respiration is affected. We can see she's having acidosis also.
So, ma'am, now it is again most of the time is covered, but fluid resuscitation again it has to be taken care of. Vasopressors are to be added. Oxygen therapy, patient has to be maintain SpO2 also. That has to be more than 95% at least. Then source has to be seen. If it is now we if till now we are not clear with the source, then source has to be clearly
No,
visualized.
that will come. That will come. So we're talking of supportive therapy. I
Then
think
we
already previous speakers have talked about
talk
giving oxygen. So you give oxygen, start with depending upon the saturation, you start with 6 liters, and then if it doesn't improve the saturation to 95, then you have to give non-invasive respiration by BPAP. And it's not a bad idea. If the patient doesn't respond, they have to be put on ventilator earlier than later, because
okay.
organ perfusion is very important. A patient has acidosis, but acidosis only need to be corrected if it is very severe with the pH less than 7.15. Otherwise, we don't need to correct acidosis
Okay.
because that can harm. So this is not required. Next.
Then, ma'am, antibiotic therapy has been covered. Monitoring, close monitoring to hold the vitals, urine output, very important. It has to be taken care of, and early shifting of the patient to either HDU or ICU. This is
So,
the thing.
yeah.
Then,
Vidushi, you can, yeah.
Yeah, so we are continuing with our case. So, in this patient, immediate management was given in the form of securing IV line and giving fluid resuscitation, as discussed. The catheter was put, which like only a few drops of urine came out. Oxygen was started with face mask at the rate of 6 liters per minute, and samples were taken for all the investigations, and of course, cultures were taken for from blood, wound, and high vaginal swab and urine for culture sensitivity. And antibiotic full dose was given. We started with meropenem, clindamycin, and vancomycin.
sure.
So after 1 hour of resuscitation, the BP remained 84/58. So the injection NORAD was started at the rate of 0.1 microgram per kilogram per
Sorry
minute.
to interrupt you, ma'am. Your time is up, ma'am.
Yeah, the BP increased a little bit. So now we are sure that she has septic shock because, like, despite giving resuscitation, NORAD, she is still having shock. So, is sepsis and septic shock different? We all know now. So we will move forward. So why? So as was highlighted previously, if the patients who fulfill the criteria of sepsis and despite adequate food resuscitation, if they require vasopressors to maintain their mean arterial pressure more than 65, or they have a lactate of more than 2 millimoles per liter, then they are considered as septic shock according to this definition given by the third international consensus. And it is associated with greater risk of mortality, 40% versus 10% when it was sepsis alone. So, sepsis in obstetrics can rapidly progress to septic shock within 24 hours in the most cases, and within 2 hours in 50% of the women with group A streptococcus infection.
So she has 5 minutes left for panel.
Yeah. It will be over.
Yes.
So, after we
Yes.
have initiated this initial management, what are the next steps? So, Dr. Alok, otherwise we'll move forward because its time is short. So the next steps would be the further monitoring as given by ACOG recommendations to identify the source for source control, and of course, by this time we should be ready with our plan for de-escalation of the antibiotics if the cultures are available, or after clinical response to therapy, or after drainage of the septic focus. So this is ACOG like recommendations for monitoring. So as we can see, mental status and pulse oximetry should be continuously monitored. The temperature and blood pressure should be monitored every half hourly till the lactates are less than 2, and then it can be monitored every 2 hourly, and urine output should be measured every hourly. So in this case, the patient was shifted to OT under GA, the cyst line was open, and the wide debridement of the necrotic tissue was done. Patient was not extubated, and she was shifted to ICU. Antibiotics were given in renal doses as the creatinine was high. So, on the second day after debridement, vasopressors could be tapered and stopped. Third day, patient was extubated. The wound culture showed MRSA sensitive to vancomycin, gentamicin, and so antibiotics were de-escalated. Only vancomycin was continued. Urine output was initially low on day 1, but later on it improved as the tissue perfusion improved, and on the 5th day the patient was transferred to the ward. So this we'll skip
We'll
and
forget this. So we'll not take the second case. I'll just like to sum up to say that we have to be, tuned to diagnose sepsis. Even if a patient like this comes who has no signs and symptoms of sepsis, but by the modified early obstetric signs, you pick up one thing like she has just
tachycardia.
Tachycardia and she has altermentation. So you go to the septic screening, you do the full investigation, and you will see that patient had uh, uh, altered liver function, altered renal function, slightly altered. So we should consider the diagnosis of sepsis in a pregnant patient in the setting of sepsis and should go ahead with the full sepsis screen even if one sign is present. That is important. And another thing I want to ask our expert, Dr. Rekha, are you there?
Yes, ma'am.
When even if we give antibiotics, sometimes it happens patient does not respond. Why does it happen?
Actually, it has already been covered in the previous lecture, but just to briefly summarize, see, the thing is that whenever we are giving antibiotics, we have to be careful about 2, 3 things. One thing is that from where the patient is coming. So if the patient is coming from a hospital or ICU, the requirement of antibiotics may be different. So probably we are not covering the actual required antibiotics. Then the pharmacokinetics and pharmacodynamics of the drugs are very important. Like we should remember few things when we are giving antibiotics. Like in aminoglycosides, we are always used to giving them in divided doses. But it is important because these drugs, they act by their initial peak levels. So if we are giving amikacin or we are giving gentamicin, it is always better to give the full dose, the single day dose. And if a patient, you have to, delay the dosage, then in these cases, when you are giving fluoroquinolones also, like you are giving ciprofloxacin, levofloxacin, ufloxacin, these drugs also should be given in a single daily doses. And if you want to adjust the doses, it is better to increase the interval rather than reducing the doses. And with the another drug, vancomycin, which we use very commonly to cover the MRSA, so it is important to keep in mind for this drug, it is important to have initial peak value and also the higher trough value. So instead of 15 to 20 milligram per kg, the initial dose which we give is 25 to 30 milligram per kg. And then you have to give them in twice a daily dose. So it because acts by both higher trough levels also and higher peak levels also. As far as beta lactam, especially the piperacillin tazobactam, this is another drug which we are very commonly using in sepsis and septic shock. In this drug, like bolus, as we say that because first,
ma'am, your time is up, ma'am.
This
okay,
is very important point.
So
Let us
we can
cover
have
this
quick
point.
comment from Dr. Ballard, Vidushi and Ajla. Dr. M.B. Ballard is there, na?
Yeah, Dr.
So
Ballard,
thank you.
we'd like to have
comment
your
and then we
opinion
close
also.
because people are desperate for test link and they are
Yeah.
filling the test link. And a wonderful panel on there.
Dr. Ballard, you're there?
Dr. Ballard, are you there? Dr. M.B. Ballard. I request Nilima to test the test link for the MCQ.
Yes,
Please
ma'am.
share because people are regularly demanding. Dr. Ballard, your comment, yes.
Yeah. I think, Sadhna, it was wonderful presentation. Really happy to see all these experts. And I attended almost last 4 individual talks, and this panel was a summary of all that, and excellent way. And I think we should prevent sepsis every procedures and save the sepsis campaign. What 2026 madam has given, I think all the postgraduates must go through that, and there are clear cut definitions and new markers they have learned. Wonderful, Sadhna. It is a nice galaxy of speakers. Really amazing to have. And thank you, Dr. Sadhna Gupta, madam, Dr. Sheila Mane, and the ICOG team, Dr. Ashok and Dr. Pratik Tambe. Wonderful. And this is what is the need of the hour, especially at community health centers and primary health centers. And this is what we need to address how important the prevention of sepsis is. Thank you. Thank you for the opportunities.
Thank you, Dr. Bella, Dr. Rekha, and all the panelists, and Achla and Vidushi conducting an excellent panel.
Ma'am, link
I
has
think
been shared in the chat box, ma'am.
Thank you so much.
There is one
for giving
more,
us the opportunity.
Sheila, there is one more webinar now. I think Dr. Sanjay Patel is speaking with the KCOG and Karnataka state
Okay, you carry
organization.
on.
Yeah, please. Thank you.
Thank you, ma'am. Bye, ma'am.
Thank you, ma'am.
Vidushi.
So
Thank you, Dr. Sheila Mane and Dr.
I
Sadhna,
think
for having us here.
Kanchan really needs to be Kanchan needs to be congratulated for having done so much hard work getting everybody together, information and collecting CVs.
Thank you, ma'am.
Thank you,
Thank you so
Kanchan.
much, and bye-bye.
Bye.
And happy
Thank you to
Ram Navami to
everybody.
all of
Thank you,
you.
Sadhana ma'am, once again for this
Thank you.
opportunity.
It was good.
And thank you, our panelists.
Wonderful panel, but we have to
Rush.
it's we don't want to put the ring the bell, but we have to because everybody is for the posters.
I
Wonderful.
think panel should be put earlier because every day it is happening. The
That
panel
is
is,
what I was thinking, Okay, we can have one special talk at the end and just prepone the panel. We will see. Next certification course, we will do that. Or we can have all 3 days panel on last day in the first session. Something like that. We'll see. We'll see what to do.
Yet we gave 30 minutes almost, Achla.
we were given 45 minutes. We had to finish in 30 minutes.
No, 30 minutes, 6:15 to 6:45.
So 30, na? And the panel time was 45 minutes.
चलो we will
I think now we will
have to
keep,
wait for
we
5
will,
minutes.
हम लोग wait करेंगे, शांत बैठेंगे. All of you, I hope all of you got the link and please scan this QR code. Okay, we will not disturb you.
Yeah.
Hello. Very good.
Ilma, how much time we have to like a time for filling MCQ? Shreya?
Yes, ma'am.
It is, time is over or still?
No, ma'am. 7 minutes more, ma'am.
7 minutes.
चेक है कि जब उस समय तक ये भी खराब हुआ तभी ऊपर आया था ना जो
नहीं नहीं वो
There is 2 minutes left, ma'am. There is only 1 minute left. Please submit your test.
So, Shreya, can we go ahead with the answers?
So, Dr. Achla, you read out the answers. No? You read out.
Okay. So,
I think only the question and the correct answer should be enough.
yeah. So,
it is there, Achla. ये सामने.
yeah, it is here.
आप शुरू कर दीजिए.
हाँ. A primary gravida in active labor requires repeated vaginal examination. What is the most appropriate strategy to reduce the risk of infection? So it is B, that you should perform vaginal examination only when indicated. No amount of anything, applying anything is going to help. Question 2, which of the following is the most important step in preventing septic site infection during cesarean section? Answer is preoperative antibiotic prophylaxis within 60 minutes before incision. Question 3, in a labor room, which of the following practices is most effective in preventing neonatal sepsis? Answer is B, early initiation of breastfeeding and hand hygiene. Which of the following is the key component of infection control protocol in the labor room? Answer is C, strict biomedical waste segregation and disposal. Which of the following best defines a multi-drug resistant MDR organism? When there is resistant to at least one agent in 3 or more antimicrobial classes. Which of the following is the key principle of antibiotic stewardship? That is, review and de-escalate antibiotic after culture results. C. Question 7. Which of these microorganisms cause puerperal sepsis? Answer is group A, beta hemolytic streptococcus. B. Which of these combination in antibiotic of choice for empirical treatment of puerperal sepsis? Answer is A, Clinda and gentamicin. Question 9. Although often considered benign, surgical thrombophlebitis can pose a risk for which complication? B, progression to deep vein thrombosis. Question 10. A 28-year-old postpartum woman presents with fever and tachycardia, which biomarker is more specific for bacterial sepsis and helps differentiate them from SARS or other? Answer is C, procalcitonin. Question 11. Which of the following biomarker is most useful for monitoring tissue hyperperfusion and guiding resuscitation? Answer is B, serum lactate. Question 12. Which cytokine is considered an early pro-inflammatory marker elevated in maternal sepsis and correlates with severity? Answer is B, IL-6. Question 13. Which of the following is a novel biomarker showing promise in early diagnosis and prognosis? Sepsin. B. डॉक्टर साधना आप लेंगी तेरा? 14. What are the maternal tests useful to diagnose PROM? Answer is all the above, that is C-reactive protein, leukocytosis, and microscopy Fern test. The FAST-M bundle in maternal sepsis includes all except steroids, that is fluid resuscitation, antibiotic, and monitoring are included. In the 1 hour bundle, which should be done first? Start vasopressors, give antibiotics, measure CVP, intubate. B, give antibiotic. 17. Initial fluid resuscitation in maternal sepsis is C, 30 ml per kg crystalloids, that is anger lactate. Question 18. Which of the following best describes the current recommended approach to maternal sepsis? Answer is C, integrated approach, FAST-M plus 1 hour bundle plus AIM. Question 19. In the management of septic shock during pregnancy, which of the following is the first line vasopressor if hypotension persists? Answer is B, norepinephrine. Question 20. Which of the following clinical picture is an early indicator of severe maternal sepsis? Hypothermia, bradycardia, B, tachycardia, and tachypnea. So I think we are done. And thank you, Dr. Sadhna and Dr. Sheila.
Thank you. I think many have submitted and they are scoring themselves also. Can we have, I really forgot to have the photograph. So whosoever is there, please make video on. Whosoever is a Sangeeta, yes. So please make video on you, whosoever is there, so we can make a good, we don't, yes. More, yes.
Chalo, good, Dr. Alok. He joined for the photograph.
So, Dr. Sheila, can we close the
Yeah,
session?
yeah, I think we should close.
So tomorrow.
See you all tomorrow. Yeah.
So tomorrow is the very, very interesting, very challenging, and the day-to-day complex decision making, that is fetal infection in pregnancy. Every time you are there, like confused, what is a torch immunological result, what is the ultrasound imaging, how to vaccinate, and the neonatal issue. We have tomorrow pediatrician as well for considering all the neonatal issues where the obstetrician is directly related. So tomorrow do join right from beginning to end, and you will find many solutions for your day-to-day clinical problem. So looking forward to see everyone.
I think our back-end office is going to have a tough time. All are going to pass. So many certificates we have to give. Okay, chalo.
We all are with them. And thank you. So we can say happy Ram Navami to all, and tomorrow we will again wish happy Ram.
Thank you, Charu. You are there. All the certificate, all the program. Charu is there for everything.
Yes.
Charu. Chalo. Bye.
Okay.
Bye.
Goodbye. Good night.
Okay, ma'am. Bye-bye.
Bye, Alok. Bye.
Thank you.
Bye.
Thank